ashes of Kathleen Folbigg is resumed.
And the witnesses are still on the same oaths. They took information they took yesterday. Yes, Ms Furness.
Thank you, Your Honour. Professor De Flue, I apologise again for my voice. Before the break yesterday, I was asking you questions about your evidence concerning the time of death of Caleb. You recall that? And in your report at paragraph 9, page 5, you say that on the 19th of February, Caleb was given a feed and put down to sleep in a room adjacent to the parents' bedroom, and he was checked by his mother at about 10 a.m.
10 p.m.
p.m., I beg your pardon, and appeared to be well, and was checked again at 2:45 in the morning. So, your evidence is that he was fed, obviously, on the night before he died.
Well, I think that's fair, yes.
And I take it that timing is upon which you base your views as to the emptying of the stomach.
Yes.
Is that right? Can I refer you to the evidence of Kathleen Folbigg, which is in a statement of hers, which is part of the exhibits before the trial, in which she says that he was fed at 1 a.m. And I'm happy to show you that if you wish. There's another piece of evidence which is in the heiress. She was involved in a question 7. She spoke again of an early morning feed. And in a diary entry, she spoke of Caleb being finally asleep at 2 a.m. And that evidence suggests that indeed he was fed probably some hours later than what you assumed in your report. Does that change the evidence you've given as to the time of death?
Well, I suppose I wouldn't call it an assumption that I've made. It's based on factual information provided.
Well, perhaps then you can tell us the facts that you relied upon to say that he was fed the night before.
Well, he was checked at 2200 hours. Now, if that is the latest possible time, what I'm saying is I'm not making assumptions, I'm basing it on material that I had. I was not provided with that other material that you now give me.
Well, then assume then what I've told you to be true,
Yes.
that he was fed at 1 a.m. Or early in the morning and finally went to sleep at 2 a.m. That means, doesn't it, that your conclusion as to the time of death must be wrong. Do you accept that?
It would be obvious that death could not occur prior to 2 a.m. then.
Thank you. Can I move on to Patrick? And as with Caleb, I'll indicate what I understand to be known from the trial, and if anyone has a different view, please tell me. Patrick was born on the 3rd of June 1990, and he had an acute or apparent life-threatening episode on the 18th of October 1990 at age 4 months and 15 days, and he died on the 13th of February 1991 at age 8 months and 10 days. As with his brother, he was full term, he was not underweight, his mother did not smoke, and he was found on his back with his face uncovered in his own bed. There were again no signs of neglect, and the family was not socio-economically disadvantaged. Differently from Caleb, not surprisingly, his mother was 22 years of age when he was born, and he was vaccinated and used a dummy, albeit the timing of the dummy is unclear. And again, the evidence is his father smoked outside. Now, because of the death of Caleb, he underwent a sleep study when he was 1.5 weeks old, the results of which, according to Dr. Cooper, who conducted it, were entirely normal. Dr. Cooper also gave evidence that an ECG which was taken was normal, and according to Professor Berry's statement, there was I think a barium test of some sort and no reflux was found. In addition, Dr. Marley gave evidence that he saw Patrick 5 times for routine childhood illnesses and injections, and he said of Patrick that he was no different from any other children. We saw him for minor respiratory infections. This is all obviously before the ALTI. And then there's evidence from Dr. Desordi, who was the neonatal consultant who examined Patrick when he was brought in to the hospital after the ALTI, and he gave evidence about his various views about it. So can I first start with you, Professor Cordner, and if you could tell us your opinion as to the cause of Patrick's ALTI?
I think it's unknown. The clinicians were, I think, uncertain. There's a little bit of confusion in my mind about the clinical course in the day or so after it, because there's a reference to almost Patrick being back to normal at one point, but at other points it seems as though there's continual sort of deterioration, really, and the development of seizures and fits. They were concerned about encephalitis, and they did lots of studies to try and see if that was the case.
Wasn't the encephalitis as a result of the ALTI rather than the cause of the ALTI in terms of the investigations that were carried out?
Well, no, there was some concern about herpes encephalitis,
As the
but that
cause
was
of the
never as a cause of the ALTI, as I understand it. And but that was, they tried to track that down, but couldn't establish that. Then over the course of the next several months, next few months, he had admissions to hospital for seizures and crises associated with...
Let me stop you there and come back to the cause of the ALTI as opposed to what occurred afterwards. You said, don't know. Is that effectively...
Yes.
Thank you. Now, you've said elsewhere in your report that the evidence that any of the children was smothered can't be excluded from thoughts of cause of death, and that applies to Patrick's ALTI, I take it too.
Yes.
Thank you. Professor Flute?
I think the brief answer is that no definitive cause for the ALTI was found. Can I just mention the difference between encephalitis and encephalopathy?
Well, you need to at this stage to answer my question, otherwise perhaps we can take it later when it becomes relevant, Professor.
There may have been some confusion in terms of understanding what encephalitis meant.
So in your short answer was in relation to the cause of the ALTI?
No definitive cause was found.
And is there a long answer you want to give us at this stage, Professor de Flute?
Not in relation to that.
Thank you. Dr. Carla?
No cause was found.
Professor Hilton?
There was a very extensive autopsy done on this young lad, including a comprehensive examination of his brain. There was major pathology found in his brain. I don't think any of us could exclude some major pathology, be it occult, as the cause of, or minor pathology for that.
Sorry, be it what?
Major or minor pathology being the cause of his first ALTI. On the other hand, his major brain pathology could have flown on from that first ALTI. The cause of that first ALTI is, like most other ALTIs, is and remains unknown.
Dr. Carla, in at trial, your evidence was that you considered it. There was a possibility that his ALTI was a result of him being deliberately smothered. Can you explain that for us? What was your basis for that evidence?
That if he was deliberately smothered, that he would have that being smothering, as we know, occlusion or obstruction of the external airway, an inability to breathe, that he may have had a respiratory and or cardiac arrest brought on by that, and that might explain the ALTI.
Thank you. Can we move on now from the ALTI? As I indicated, Patrick died on the 13th of February 1991, some 3 or 4 months after the ALTI. And the evidence as to the circumstances of his death is that he was found by Craig limp and warm on that morning. The ambulance reports him to have been normal stroke warm to touch when they attended at 10:10 a.m. And there was no death scene examination. And the death certificate recorded his death as asphyxia due to airway obstruction for an hour and epileptic fits for 4 months. And then there were the autopsies. Perhaps if we could have on the screen tab 17. Now, the autopsy records that the time and date of death was on the 13th of February at 10:40, and the post-mortem was at 12:30, and it was conducted by Dr. Bishop and Dr. Sinkara. Now, Dr. Bishop was Dr. Bishop a forensic pathologist? Do you know Dr. Carla?
No.
Do you know Professor Hilton?
No, he wasn't. He was a trainee. He was an advanced trainee anatomical pathologist.
And Dr. Sinkara?
He was, as far as I know, was in fact an anatomical pathologist.
Thank you.
So could I just interrupt?
Certainly.
I think Professor Hilton's may be referring to Dr. Jan Bishop
Brian?
and Dr. Sinkara, and I agree Dr. Sinkara was a trainee in anatomical pathology, but I think Dr. Jan Bishop was either head of anatomical pathology or a senior anatomical pathologist at John Hunter at the time.
Thank you.
Dr. Caller's right.
Thank you. And then you see the clinical diagnosis in the autopsy of part 1, and then the macroscopic diagnosis, and then there's reference to the clinical history. Now, in terms of the autopsy, having a clinical diagnosis, is that a process which occurs prior to determining a cause of death? Dr. Carla?
So this, to answer your question, this case was initially not referred to the coroner. Mm-hmm. So this is a hospital autopsy.
Thank you.
Quite different from a coronial, where consent from the next of kin needs to be obtained before the autopsy is done, and further, a valid death certificate has to be written and presented to the pathologist doing the autopsy prior to the procedure being undertaken. So it is standard practice for the clinical doctors, that is the treating doctors, to offer up a 1 or 2 line diagnosis as to what their views are with respect to the cause of death.
And so this is the cause of death of Dr. Wilkinson, who's named as the medical officer, is that right?
I believe so, yes.
Is that how we're to read it?
Yes.
And perhaps Dr. Morris?
Yes.
Thank you. And referred by is the GP who looked after Patrick, Dr. Marley in Newcastle.
Yes.
Thank you. And then there's reference to the clinical history, which is largely what I indicated earlier. And then there's various investigations. The first is that biochemical and cytology studies were normal and the herpes culture was negative. Does that mean anything? Professor de Fleu?
It's a negative result. all or almost all lab tests have false positive, false negative results. You cannot take it in isolation. You consider it with clinical symptoms as well. But the chances are that it was negative.
And the scan of the cranial CT scan of the cranial CT scan that's described halfway down the page says hypodense areas in the temporal and occipital lobes secondary to viral encephalitis, ? Presumably the question mark means perhaps.
That question mark could, in my view, probably relates to the demyelination disorder.
So what comes after rather than before? In
That's
the
how
centre.
I interpret it as likely being the case.
Professor Cordner?
Could you repeat the question, please?
Well, if you look at the paragraph I was referring to, is the question mark in relation to the encephalitis or what came after?
Well, I think they concluded that viral encephalitis was not a factor in the death.
Thank you. If we turn over then to the macroscopic report, external appearance is of a well-nourished male infant and there were no signs of trauma and no abnormality. And over the page, turning to the respiratory system, under the heading lungs, there's reference to both lungs being congested. Now, Dr. Carla, does that tell us anything?
No.
And then moving down to the thymus, it was enlarged. Does that tell us anything?
No, that's essentially normal for a child of this age to have a thymus weighing 30 grams.
And then the liver was congested.
A non-specific.
And then we turn over to the investigations on post-mortem tissue on the next page, down the bottom of the page. And there's reference to previous ECG monitoring which showed no abnormality and arrhythmias were never quoted clinically. This was thought to be very unlikely. Can you help me with that? Seems to be inconsistent to me, but what do you read that to be? What was thought to be very unlikely? A cardiac conduction defect? Is that how one should read it?
Yes, well, I don't know about that, but possibly. But arrhythmias, the final part of the first sentence, arrhythmias, that is abnormal rhythms, were never noted clinically, that is during Patrick's lifetime. So the second sentence to me indicates that the treating doctors felt that some abnormal cardiac rhythm disturbance or a cardiac rhythm disturbance was thought to be very unlikely.
Do you agree with that interpretation, Professor Defleet?
I think it has to be read with what is written over the page as well. Effectively, as I read it, Dr. Bale, a paediatric pathologist from memory, was asked if the cardiac conduction system, the AV ring, should be examined for the possibility of cardiac conduction disorders. And her view was that it would be unhelpful in general in this case, that there was no direct clinical indication for it.
Because there was no abnormality in the ECG monitoring and the arrhythmias were not noted?
Cardiac conduction arrhythmias, yes.
Yes, thank you. Now, turning to tab 20, unless anyone wants to say anything more about that part one of the autopsy. Did you want to say anything more, Professor Cordner? No one else? So tab 20. Now, given what you said before, Dr. Carla, about a hospital and a coronial autopsy, Can you tell us what that document is?
Well, it's headed Hunter Area Pathology Service, Division of Anatomical Pathology, Mater MMH Autopsy Report, Mater Misericordiae Hospital Autopsy Report.
So is that a different autopsy report or a different stage of the autopsy conducted in relation to the report I just showed you?
My understanding is it's a different stage, and I think possibly a later stage.
Thank you. And you see, again, there's a clinical diagnosis,
Yes?
and that clinical diagnosis is the same as the clinical diagnosis earlier, and then there's a formal diagnosis.
Final diagnosis.
Final diagnosis.
Yes.
Now, what does that final diagnosis tell you, Dr. Carlin?
Well, I'll go through both points. Normally formed male infant of approximately 8 months of age, and then I don't think any further comment needs to be provided. And then the second part, old infarcts and gliosis in the parieto-occipital area, brackets both cerebral hemispheres, which are probably secondary to the cardiorespiratory, I think, arrest. So arrest should be following cardiorespiratory, suffered at about 5 months of age. So an infarct is ischemic necrosis, in other words, death of tissue caused by an interruption to the blood supply to that area of, to that tissue. And gliosis refers specifically to repair tissue in the brain. You don't get gliosis in other parts of the body, only in the brain, and it's in response to an injury or an infection or some prior insult to the brain.
So it's repair injury, it's not scar injury. It's
Yes, gliosis is colloquially known as a brain scar.
Thank you.
And in the parieto-occipital area, so the parietal area is a lobe in the brain above the ear. So there are 4 lobes: frontal at the front, of course, temporal above the ear, and then parietal above and behind temporal, going towards the back of the head, and occipital is at the back of the head.
Now, that final diagnosis, how does it sit with the clinical diagnosis?
So the clinical diagnosis, there's line 2, asystolic cardiac arrest at home leading to death. And then, so that's the final event.
It doesn't tell you what caused the cardiac
No, that's correct. Sorry, I'm getting ahead of myself perhaps. But the final diagnosis, ignoring line 1, which just says normally formed infant, but the second line refers to the ALTI that occurred that resulted in infarction or death of tissue due to interruption of its blood supply, with repair or gliosis in these areas of the brain, and which is felt to be, so the pathologist has said, in their view, the infarction or infarcts, multiple infarcts, and the repair that followed was secondary to a cardiorespiratory arrest at about 5 months of age.
So how does the encephalopathy fit in with all of that?
Well, an encephalopathy is just a broad term without going to the cause, which says abnormality of the brain. So some abnormality of the brain occurred without them saying exactly what it was, but that at the end of that, as a result of that, there were intractable or untreatable seizures.
But it doesn't say he died from the untreatable seizures, does it?
No.
Does it say what he died from?
No. It sets out what this child was thought to have had. The intractable seizures are frankly unarguable. There's good documentation of that. But then it says the underlying cause of encephalopathy or the brain abnormality, not determined on investigation. However, they have shown abnormalities in those parts of the brain, as I've described, old infarcts and gliosis.
Thank you. Now, Professor De Fleu, did you want to say something about encephalopathy?
Thank you. What I specifically wanted to say is that encephalitis is a form of encephalopathy. It is one of many different causes of encephalopathy. The two should not be confused.
Who are you
Encephalitis.
suggesting has confused them, Professor?
I was worried that people in the court might be confused on the basis of an understanding of the difference between encephalopathy and encephalitis.
So you've seen nothing in the written material that suggests somebody significant was confused?
No, not at all. It worries me in terms of education of the court, if you like.
Have you educated the court, or is there more you want to say?
No, I think that was my concern.
Thank you. Professor Cordner, did you want to say anything?
I'm just wondering if you're aware of the cause of death as written on the death certificate.
Yes, I had dealt with that before. Thank you. Well, turning over the page, there's reference to post-mortem blood cultures. Do you see that at the bottom of the page? And there's references to what was grown. Professor Cordner, can you tell us about that?
So we're looking at the second page of this Hunter Area Pathology Service document at tab 20, is that right?
Yes, it should be on the screen.
Yeah.
You see it on the screen, the heading, the post-mortem blood cultures paragraph? So it tells us that there were various things that were grown from the cultures.
Yes, well, it is interesting that this autopsy was undertaken very soon after death, and that one of the problems with post-mortem...
Perhaps if you could just talk a little
yes,
closer
I will,
to the
yeah.
microphone.
One of the problems with post-mortem microbiology is that as the post-mortem period lengthens, then bacteria and other organisms from the gut start spreading around into other parts of the body through veins. And so to avoid that, a very early post-mortem is a very good thing. So it is interesting that in an autopsy started 2 hours after death, that there is such a rich yield of bacteria. Now, but they do look to me like they're gut flora. But I am happy to be educated further about what other people think. They're mixed organisms, and so the next sentence goes on to say they're not significant and probably reflect contamination. So maybe the pathologist thought that perhaps his sterile technique wasn't as good as it could have been. So you asked me what I thought, and I'm just trying to express that.
So is it your view that it would be likely that they probably reflect contamination, or you don't know from
Well,
what
I
you've
think
read?
that probably the explanation, yes.
Thank you. Professor De Fleu?
Yes, it is interesting that there are multiple bacteria in blood culture. It is a short post-mortem time interval. I think it's fair to say that orthodoxy amongst forensic pathologists has it that would be categorised as likely contamination.
Thank you. Dr. Carlin?
I believe it reflects contamination.
Professor Hilton?
I think all my colleagues agree that this is an area of considerable controversy. These are all gut bugs. The samples were obtained about 2 hours after the child was formally declared dead. That's a very short time interval for bugs to spread from the gut to the various sites from which they were recovered and grown. Some recent work has suggested that this is not uncommon as a lot of us thought.
Is not uncommon.
Not as uncommon. The rapidity of spread, if you like, is not as uncommon as many of us thought. Nevertheless, to cut to the chase, these are, I think, incidental findings and probably do reflect contamination irrespective of how it got there.
Thank you. Now, Professor Blackwell, who we referred to yesterday in terms of Caleb, said about Patrick that, and I quote from her report, as the post-mortem examination was carried out 2 hours after death, it is difficult to dismiss the findings as contamination, as there would have been little time for breakdown of mucosal barriers. If this were contamination from the gut, a large variety of organisms would be predicted. And evidence of infection prior to death was noted, just dealing firstly with a larger variety of organisms would be predicted. Is that right, Dr. Professor Cordner?
So, I thought I heard you say that there was evidence of illness before death.
Well, Professor Blackwell is saying there's evidence of infection prior to death, and what she is referring to is that at 11:30 the night before he died, Patrick was vomiting, had a fever and was sweating, and that's by reference to a case record by Dr. Colley. Attachment G.
Yes, well, now this, my type of response to the situation now is this is precisely the sort of situation that shows the value of having a proper case conference after sudden unexpected deaths in infants, so that the relevant experts can be gathered together to sort this out. Now, my view would be that it would be relatively unlikely or relatively unusual to get 3 organisms growing from a blood culture taken to investigate, for example, a fever that you have described, which of course doesn't mean that it couldn't be one of them and others are contamination. So look, I think it is correct to bring up the fact of the illness before death as altering somewhat the context within which you have to consider these blood culture results.
And how does it alter your view of the blood culture results? Your evidence was it was likely to be a contaminant.
Well, without the benefit of getting other expert advice, my reaction is that it's likely to be contamination. But I have a low bar to getting expert advice.
Thank you, Professor. Professor De Fleu, do you want me to read again what Professor Blackwell said?
No, I recall. Look, my view is that Professor Blackwell is an expert in microbiology. I'm an expert in autopsies. I suspect more likely than not, using again forensic pathology orthodox teaching, that this is likely contamination, but I certainly don't exclude entirely reasonable possibility that Professor Blackwell is right in this case.
And what's she right about? She's only raising something.
Yeah, no, that she's raising this as a possibility.
Well, she's not even raising it as a possibility. She's just saying there was evidence of infection prior to death. So she says that a statement of fact.
Well,
As I read it, perhaps I'll read it again so everybody's clear. As the post-mortem examination was carried out 2 hours after death, it is difficult to dismiss the findings as contamination, as there would have been little time for breakdown of mucosal barriers. Now, you've all given evidence about that, and you've all given evidence that it probably was contamination. Then she says if this was contamination, a larger variety of organisms would be predicted. That's one point. Secondly, she says, as a matter of fact, evidence of infection prior to death was noted at 11:30 the night before he died. Patrick was vomiting, had a fever and was sweating. And she references Dr. Colley's notes. So she draws no conclusion from that. She merely states it as evidence that was available from Dr. Colley. So when you say you're accepting, what is it? Are you accepting the first point? That is that you would expect a larger variety of organisms would be predicted?
it's my experience in autopsy cases where there is contamination that this range of organisms, or where we believe there's contamination, this range of organisms is not unusually reported. So I maintain of the view that, at least from my perspective, I think that contamination is likely.
So having considered, Dr. Carla, what I have read as Dr. Blackwell's opinion as well as statement of fact, does that alter your view?
No.
Professor Hilton?
Dr. Colley's clinical, I've got no reason to doubt Dr. Colley's clinical observations. I agree with Dr. Blackwell that this could indicate the presence of an infection in life. The range of bugs that were cultured after death may have absolutely no connection with the clinical presentation several hours before. In my opinion, and I think this is pretty well unanimous with all of us, is that the likely explanation of the presence of these 3 particular germs at post-mortem is a contamination irrespective of the actual mechanism by which they got there. It's either contamination that the collection process was dirty. It's either, or it could be contamination because of an efflux of these germs through the dead bowel after death into the circulation and being disseminated. Now that might be thought to be a bit unlikely because in anatomical terms, it's a long way for a little bug to crawl from the gut to the site of collection. Nevertheless, it's been recorded so often it can't be discarded as a route of contamination. It's controversial, but that's the best. That is my best reading of
What's controversial? What's controversial?
The presence and significance. The presence isn't controversial. The significance of 3 enteric germs at sites distant from the bowel at post-mortem.
It's not controversial among the 4 of you.
It's not, well, we think it's all contamination.
Yes, so...
But there are other people who have got different views.
I beg your pardon?
There are other people who may have different views.
You may have or do have.
I think Caroline Blackwell may have, but that's...
She's not a forensic pathologist.
She's a microbiologist, and she's a good microbiologist, and she's reputable, and she's honest in her opinions.
So the controversy is in relation to Professor Blackwell having stipulated what she did, a different view held by the 4 of you.
Well, yes, I think it's common ground that if she's attributing if she of necessity is attributing the clinical signs of infection the previous evening to one or more of these bugs, I would regard that with some trepidation.
Well, I've read to you what she said. It's up on the screen. Is it? No, we're talking about Patrick, not Sarah. So go up. Can we see the beginning of the earlier page, please? What she is saying is that as the post-mortem examination was carried out 2 hours after death, it is difficult to dismiss the findings as contamination. You've all expressed your view as to that. And she gives a reason for why she says that, but you've expressed your views to the contrary. And then she just says there was evidence of infection prior to death and states what that evidence is. She doesn't draw any conclusions in relation to that at all.
Yeah, there's a juxtaposition to them.
Beg your pardon?
There is a juxtaposition in her overall opinion between these bugs and the infection.
So you're inferring that she's saying, although she doesn't actually say it expressly, that the infection had something to do with the contaminants in the gut.
I suspect that might be in her mind.
And you don't agree with that?
I think I think these gut germs are contaminants, and I think it would be very unsafe to, from a medical point of view, to correlate the presence of these bugs recovered at autopsy with the febrile episode that Dr. Colley observed the previous evening. Maybe one of them, all of them, I really don't think so. Or it may be a different infective organism that was not detected.
Thank you. Now, can I come to each of your views about the cause of Patrick's death? Can I start with you, Professor Cordner?
Yes, well, the cause of death as actually appears on the death certificate, which represents the final view, was...
You can have that up on the screen if you'd like, Professor. It's tab 16. So the death certificate, as I indicated before, is asphyxia due to airway obstruction. Perhaps we can scroll up. 1 hour and epileptic fits 4 months.
Yes, so what whoever signed this death certificate is saying is that the underlying cause of death was epileptic fits, and that mediated death through what is described as asphyxia due to airways obstruction. And the asphyxia due to airway obstruction is an inferential statement, not based on any observation, but based on an understanding of how seizures might lead to death. Okay?
The way one can read this certificate is the first line is cause of death, asphyxia due to airway obstruction, and then the second line is and duration of the last illness.
Well, the first line is
Sorry, just let me finish, Professor. So is it the case that the epileptic fits should be read as duration of the last illness or part of the cause of death?
The way to read it is the 1A, the cause or condition directly leading to death due to or as a result of 1B, epileptic fits. That's how to read that.
So the epileptic fix caused the airway obstruction
That's
referred
right.
to in A.
Yes, that is how that is constructed on the actual form of the death certificate that you fill in as the doctor from the Registrar of Births, Deaths and Marriages.
Does that mean there's no reference to a duration of a last illness then?
Well, there's 4 months in relation to epileptic fits.
So that's a reference to duration of the last illness as well as a cause of death.
Well, I don't think it's no, I think it is a reference to how long has the condition which was the underlying condition causing death been present.
Do you agree with that as a cause of death?
Well, in my report, I've got a different recitation of what I thought had been in the materials somewhere, and I can't quite find it right now. But I doubt that I made this up.
Where were you referring to in your report?
Page 14.
Page 14. So we can have that on the screen. Just perhaps to be of some assistance, I think earlier in your report you indicated that your summaries were taken from Professor Berry's report.
Yes.
So we can assume then that it's taken from Professor Berry's report.
Well, I'm not sure whether I did get that from Professor Berry. I think I said at the beginning that it was largely based on Professor Berry.
So tell me what you're referring to and we can check whether it's Professor Berry as the source.
Well, it's 1A and B are the same, but that there is a 1C,
Right.
encephalopathic disorder. In other words, the epileptic fits are due to or a consequence of encephalopathic disorder.
And that isn't what the death certificate says.
That isn't what the death certificate says. It left out the 1C.
Was
So-
it left out or it wasn't there?
I'm sorry?
It's either left out or it wasn't there in the first place.
Well, yes, I suppose so. The epileptic fits just sits there on the death certificate without any attempt to define why there were epileptic fits. And so the encephalopathic disorder, as has been already discussed, is the underlying cause of the epileptic fits.
That's your view.
Although it doesn't take you much further, that is my view. And the epileptic fits could have led to death by some form of, well, it's thought that there are two possible ways, and there are probably more, but the two main ways in which seizures can result in death are one, that there is prolonged obstruction to or absence of breathing associated directly with the seizure.
So the seizure obstructs the airway in some way?
Yes. And or there is a centrally mediated through the brain interference with the neurological pathways for breathing. Or two, that there are arrhythmias or disturbances to the rhythm of the heart directly associated with the seizures.
There's no evidence of arrhythmias with Patrick, is there?
Now, I'm talking about how epileptic seizures, generally speaking, cause death.
I understand that and I'm applying it to Patrick. Is there any evidence of arrhythmias?
Well, there's no evidence of there's no evidence of anything directly leading to his death.
So any of those three matters you referred to don't apply to Patrick, is that right?
No, that's not right.
Perhaps you can explain it for me.
Well, I'm trying to, your original beginning of this conversation was to explain the terminology as used on the death certificate. Your invitation to me was to try and explain it, or my view about it. And so I'm trying to explain that the doctor felt that the underlying cause of death was epileptic fits. And then I've tried to explain how it is generally thought epileptic seizures or fits result in death. And that's what I believe the doctor has tried to do in 1A, referring to asphyxia due to airways obstruction, which well, we've had the discussion about asphyxia, so I wouldn't have used that word, and I would have used the terminology of something like consequences of epileptic seizures secondary to encephalopathic disorder. So
So is your view consistent with what you've written?
well,
Yeah.
I think I was rather thought that the underlying cause of death, the epileptic fits due to encephalopathic disorder, was a reasonable summary explanation for provision of the cause of death in this case.
And the underlying cause of the encephalopathic disorder has not been determined.
That's right.
By you adopting this cause of death, I understand what you're saying about the use of the word asphyxia, is that Patrick died from an obstruction to his airways, which may have been caused by or due to epileptic fits, which were themselves as a result of some encephalopathic disorder, and it's not known what was the cause of that disorder. Is that an explanation?
Yes, I mean, just to be, perhaps just to be too particular, there's no way that the doctor can say airways obstruction, so it could be any mechanism by which epileptic fits causes death, and that includes arrhythmias to the heart, it includes centrally mediated stopping of breathing, it includes airways obstruction.
Just let me stop you there. I understood your evidence to be that you accepted that this was the cause of death. Is that right?
Yes.
And what I was putting to you was that your view was A, B and C, as you set out here, notwithstanding it's set out as though it was the death certificate cause of death. We know that's not true, but that's your view of Patrick's death. Not the doctor's, that's your view.
No, the view that's on the screen there is what I thought was the doctor's view.
What's your view?
My view is that the cause of death is the consequences of epileptic seizures due to encephalopathic disorder.
And the underlying cause of that has not been determined on investigation?
No, but that is correct. But I do want to make it very clear that the death is very understandable in the circumstances of a baby having severe epileptic seizures.
And you've said elsewhere in your report you can't exclude smothering in relation to any of the Folbigg children, and that applies to Patrick's death.
Yes, but you've said can't exclude smothering in any of the Folbigg children, but there are good grounds for thinking that in at least one of them there is no smothering. There are very good grounds for thinking that Laura was not smothered, and there are good grounds in this case. There is no real need to go searching for another cause in the circumstances of a child having intractable seizures. Death from that is well recognised and something that we see not infrequently.
Professor, could you define for me encephalopathic disorder?
Well, encephalopathic disorder, as Dr. Carla was describing, is a general term that simply means there is something wrong in the brain.
Thank you.
Professor De Flue, what is your opinion as the cause of Patrick's death?
In my report, and as I believe today, my opinion is that the cause of death can be described as the consequences of hypoxic ischemic encephalopathy brought on by an acute life-threatening event or an ULTI of unascertained cause.
It's not dissimilar to 1C that's on the screen.
Yes, it isn't dissimilar at all. I suppose what I leave out of this is epilepsy, in that it's possible that the final event may have been epilepsy, causing death again through multiple means, as mentioned by Professor Cordner. But I think I can't tell that for sure.
Did you take into account in coming to that view the death of Caleb?
Yes.
And how did you factor in the death of Caleb in coming to your view?
Well, my view was that the appearances of Caleb's death was that of a SIDS type death, while this is not a sudden death. It's arguably not unexpected death, but a death with some significant pre-existing pathology. Now, the nature of the pathology is unclear in terms of, well, the nature of the pathology is clear. The cause of that pathology is unclear.
Does that mean you effectively dismissed Caleb's death because it was sufficiently distinguishable?
Well, I don't dismiss the death.
In terms of coming to a view as to Patrick's death?
I have given, I think looking at Caleb's death, that can be explained readily. And I think that Patrick's death can be readily explained.
So the weight or the way in which you took into account Caleb's death, given as you've said it was of a different variety, was what?
Well, Caleb had typical features of a SIDS type death.
Understand it was different for those reasons. Given that it was different and given that you've given evidence you took it into account, how did you take it into account given your view that it's different?
I considered it.
Did you put it to one side?
No, I considered it in the first place, then considered this death as well. Did I totally remove it? No. Did I include it as in some way the two must be related? No, I didn't do that either.
What do you consider Patrick's death to have been in isolation, that is, looking at Patrick's death only?
I think that's still the cause of death as I've given.
Dr. Carlin?
You're asking me about Patrick's cause of
Cause
death?
of death, I am.
I'd say undetermined. I simply don't know. I accept the pathology that was found, but I don't know, and I'm not convinced about the final acute immediate cause of his death. I don't know. I'd like to leave it open. I say that looking at his death and the medical history that's known and the immediate circumstances, and also knowing that there was a previous death of Caleb, for which, as you know, I would also give the cause of death as undetermined. So I would prefer to keep it open and just say undetermined or unascertained. They mean the same thing.
When you say you accept the pathology, is that the fact that Patrick had seizures?
Yes, and that he's got the gliosis and infarcts as fact.
Thank you. Professor Hilton?
Yeah, I think this little lad died, or the indications are that this little lad died as part of an epileptic type illness. The pathology shown at autopsy in his brain explains why he was brain damaged and why he was quite likely to be having epileptiform fits during his life. This in turn may have been at least initiated by his ALTI, whatever an ALTI is, and whatever may have caused that ALTI. So there's a logical, but not necessarily correct, progression from ALTI to epilepsy to death. And epilepsy is a well-known, whatever form epilepsy takes, is a well-known cause of death, And in fact, there is a acronymous term being adopted for sudden death in epilepsy.
When a person or child, baby, dies of epilepsy, would you expect there to be some signs in the mouth or around the mouth as to something that may have blocked the airway, tongue, or some biting or something indicating that a seizure had preceded?
Not necessarily something that would be observable at autopsy.
But such signs can be
Yeah,
seen.
sure.
And are you able to say whether they're often seen,
No,
often not seen?
No.
They just are sometimes seen and
there's
sometimes
sometimes,
not.
yep. And this is in the clinical management of epilepsy as well.
No.
This is these are seen in the clinical management of epilepsy too. That biting the tongue is the most commonly accepted observation, although I don't know how common even that is.
Dr. Carla, do you have anything to add to whether or not one would expect signs if an epileptic seizure preceded Patrick's death?
I don't think I would expect signs, and I agree that tongue biting might have occurred. So not so much in a child with absent teeth, but in an adult, you may see teeth marks on the tip of the tongue and the sides where the molars and the incisors have come down and bitten the tongue. That is not always seen at all, but if it was seen at autopsy, that's an inference that possibly a seizure has occurred just prior to death. The other thing is passing urine, but that's quite non-specific. A lot of people pass urine around the time of their death. In a child, though, there's often no sign, and I agree there's no sign of airway obstruction.
You, I think, have said in your report to the inquiry that you were concerned that Patrick was smothered. Were there any signs that you have seen from your review of the materials that are the same as smothering?
No, I haven't seen anything specific for smothering.
Does that affect your view that you're concerned it might be smothering?
It doesn't affect my concern. It is a concern. I can't take it any more than that.
Thank you. Now, Dr. DeFlew, you also formed a view about Patrick's time of death. And if we can perhaps have your report on the screen. I think it's at page 30. Excuse me. It's down the bottom of page 30.
Yes,
It's not my page.
it's the last paragraph on page 30.
You need to take it. No, page 30 doesn't appear to be on the screen. That's page 13 on the screen. I accept that it's probably my pronunciation. So, you start by saying time of death is not able to be determined from the information provided.
Yes.
Now, you didn't stop there.
No.
But, given the only physical description provided was that the body was warm to touch, it is entirely possible for Patrick to have died at any time from when Craig went to work to when the ambulance officers arrived, with a later time being more likely than an earlier time.
Yes.
When you say the only physical description provided was that the body was warm to touch, I mean, one would not expect any other physical description about temperature, leaving aside whether the child was limp, would one? What other physical description would you be looking for time of death other than, again, limpness?
Not at all. Uncommonly, you would get information from an ambulance report of the presence or absence of post-mortem lividity, presence or absence of rigor mortis. both of those are commonly mentioned, in my experience, in ambulance reports. But their absence of mention is not an indication necessarily that they weren't present.
So the evidence is that Craig found him limp and warm. Limp suggests that Craig found him sooner rather than later after he died. Isn't that the case? You haven't mentioned it. It's
Sorry. I suggest he died closer to the time the body was found rather than further away.
well, you say that it's entirely possible for Patrick to have died at any time from when Craig went
Correct,
to work.
yes.
When did Craig go to work?
I have here that, and I refer to paragraph 15 of my report.
Paragraph 15.
15
What page is that on?
on page 7.
Yes.
So I don't have a specific time, but I think if it can be accepted that that was the last verified, confirmed occasion when Patrick was last seen alive, I don't know what time that is. I haven't been able to determine that time with any, at all.
Don't you need to know that time to make the observation or give the opinion that you've given?
I think entirely reasonably, Patrick could have been dead for, to pick a number, let's say 3 hours. That wouldn't surprise me. He may have been dead for 5 minutes. That wouldn't surprise me either. But in general, the fact that he's warm suggests more likely that I'd push it to closer to around the time that Mrs. Folbigg expressed her concerns, rather than some considerable time previously.
However, your reference to Craig having gone to work is not one that we should be giving any credence to, given that you can't tell us when that was. Do you accept that?
I don't know what time that is. I suspect that time is known, but I don't know it.
No, I understand you don't know it, but the fact that you've given it as one end of the possibility, that is, at any time from when Craig went to work and when the ambulance officers arrived, without knowing that first time, it renders it somewhat meaningless.
Look, I accept that, and I suppose what I've done is I've made an assumption of a normal start of day time of work. Is that valid? Maybe not. But as I've said, I'm sure the time is known.
But the question is whether it was known to you because you wrote the report.
And that's why I
You
said
understand.
I do not know it, and that's why I start that paragraph at page 30. The time of death is not able to be determined from the information provided. That's how I start that paragraph.
Should we put a full stop after that?
It certainly can't be determined with any degree of certainty.
Now, unless anyone wants to say anything more about Patrick's death, anyone to my left?
I would have a comment if
Certainly, Professor Cordner.
I'd just like to go back to Professor Palanen's categorisation of different levels of evidence for establishing causes of death in different sort of contexts, which is page 4 of his report. Just to point out that this cause of death, I believe, the death in this case fits squarely in category 3, which is what he thought too. So that is potentially fatal chronic pathological findings, the findings in the brain that imply the cause of death, as from epileptic seizures, which we know he suffered from, based on correlation with the history, and there's nothing to suggest that epilepsy wasn't the cause of death. So it seems a reasonable conclusion to fit into his category 3.
Thank you. Can I turn now to Sarah? Sarah was born on the 14th of October 1992 and died on the 30th of August 1993, aged 10 months and 16 days. And as with her siblings, she was full term, she was not underweight, her mother did not smoke, and she was found on her back with her face covered in her own bed. However, she slept in a cot in her parents' room, unlike the other children, which evidence was given on Monday as a protective factor. Again, there were no signs of neglect and the family was not socio-economically disadvantaged. Her mother was 25 and she was vaccinated and used a dummy, again, the extent to which is not perfectly clear. When she was born, she went home with an apnea alarm and slept with an apnea blanket, even though the use ceased before her death. And as with Patrick, Dr. Cooper performed a sleep study on Sarah when she was 3 weeks old, which showed a small handful of apneas which were normal for infants that age. He couldn't tell whether they were central or obstructive, but in her age they were likely to be central. It goes along with a normal study for an age of a child at that age, he said. And then his conclusion was that the sleep study ultimately conducted was normal for her age. She also had a metabolic screen and there was no need to follow that up. Dr. Marley, her GP as well as Patrick's, saw her 5 times for routine reasons such as vaccinations and a viral infection of mild severity, and he said that she appeared to be normal, healthy infant. Now, if we can get up tab 32, which is the report of the death to the coroner. So this clearly was, Dr. Carla, ultimately a coronial autopsy.
Yes.
If we can just scroll down, we have her last seen alive at 12 to 12:30 a.m. on Monday the 30th of August and reported to the police at 2:45 a.m. And then if we can scroll up further, there's reference to having been treated by Dr. Marley with a prescription of Folbigg, prescribed on the 18th of August, and that she had a flu or cold type virus. And other than that, the child was eating normally, all foods similar to parents, and last ate at about 5:30 p.m. and was then put to sleep in a bed in her parents' room. So that can be taken down. And then the ambulance reports in relation to Sarah were inconsistent in that there was both cold and warm indicated at various stages. So perhaps we could then have the autopsy report, which is tab 34. I take it no one has anything more to add to that general description of before her death? No? Professor Cordner?
Sorry.
Do you have anything to add to what I've said about the circumstances prior to Sarah's death?
No.
So, Professor Hilton, I think you're the appropriate person to ask about this. You conducted the autopsy, and at the time you conducted it, what was your position at the Institute?
I was director.
You were the director. Thank you. Now, you conducted it at 8 in the morning on the 31st day of August. So that's the morning of her death. If we can just keep scrolling down. And turn to external examination. Now, you note that rigor mortis was generalised. Does that tell us anything?
Pardon?
Does that tell us anything? The rigor mortis was generalised at that in the morning? Doesn't help you with time of death? No?
No, it doesn't help.
Now, there was a 1.5 centimetre scratch on her right upper arm.
Yes.
That tell you anything?
Some possibly sharp object, which could have ranged from a fingernail up to anything you like, had been drawn across that part of her arm at some time in the recent
Nothing
past.
significant as to cause of death?
No. I mean, it's significant because it's there, therefore it warrants mentioning, but it's got nothing to do with the cause of death.
And then there was minor abrading and drying of the lips.
Yeah, that's post-mortem artefact.
And then if we can turn over the page, there were 2 tiny punctate abrasions present, one immediately below the lip,
Yep.
lower lip on the left side, and the other slightly to the left side of the midline of the chin. What does punctate mean?
Pinpoint.
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 Thank you. Now, you didn't take a photograph of those abrasions.
I certainly did not take any photographs of this child.
Can you now, based on recollection, tell us what they looked like or not?
What
Looked like or not?
the two two,
Yes.
yeah, well,
Time
they were
ago.
tiny pinpoint, just defects in the outer skin.
Defects in...
The outer skin.
What did you think of them at the time?
What's the?
What did you think about them at the time?
Well, we pinpoint marks such as this are not entirely uncommon in kids. Point 1. Point 2, there have been fairly vigorous attempts at resuscitation on this child, both domestically and professionally, which are failed. Vigorous resuscitation not infrequently leaves, if you like, witness marks, such as drying, well, that's more post-mortem, but abrading of the skin of the lips, sometimes internal damage, sometimes external damage. So the child had been, setting aside the previous, that this may just have happened, the child has been resuscitated and it's been transported, and any of these factors have to be considered in considering the etiology of these small and relatively insignificant features.
When you say she had been vigorously resuscitated,
Yep.
what does vigorously resuscitated mean?
Well, mouth-to-mouth breathing type exercise and chest compression.
That's vigorous.
Big one?
That's vigorous.
Yeah. Well, it's not vigorous, it doesn't work. I mean, it's got to be vigorous, there's got to be a sufficient force applied to compress the chest wall so that it squeezes the heart between the breastbone and the spine. Now, in a child, this is much easier than it would be, say, to an elderly person such as me.
So it's not the compressions to the heart that would have caused those marks, is it?
No, I don't think so.
It's what you described as the mouth-to-mouth
Yes.
resuscitation.
Yes.
Is that with the use of some form of mask or just literally
I
mouth?
think the Ambos used a device called a Goodell's airway, which is a little curved tube, if you like, with a lip, and you pop it into the mouth. The lip on the tube, I don't want to confuse people, the lip on the tube compresses as applied fairly firmly to the lip on the person. The curved part of the tube goes over the top of the tongue, keeps the tongue forward, and hopefully directs air or oxygen down to the larynx through into the trachea, through into the bronchi, into the lungs.
And is that what you believe may have caused those abrasions?
That's something that's got to be considered, and it's something that's commonly seen in the lips of the person who has been
So you
treated.
commonly see abrasions like this on children?
Yes.
And in your view there, if there's been a Goodell airway used, that's been the cause of it, is that right?
Well, it's an eminently credible cause.
Can I just stay with the abrasions for the moment? Dr. Carley, you obviously weren't present at this autopsy, were you?
No.
And the information you have is the information from the autopsy report?
Yes,
You've not had access to any other material other than the autopsy report?
that's correct.
What opinions do you form from the sentence that's in that report?
Up the top that there were 2 tiny punctate abrasions. I don't know what the cause of them is. I accept what Professor Hilton said about resuscitation causing injuries around children's mouths and on the face. I do accept that. I have to say I've done many autopsies on children and not many of them have had abrasions to their lips. They have, after death there is some drying of the lips, undoubtedly, but abrasions are, in my experience, unusual, but it's also fair to say that they may be caused by resuscitation attempts. Any manipulation around an adult or a child's nose and mouth, such as what happens when resuscitation is attempted with the insertion of tubes, can cause injuries. So I think all pathologists accept that there is a vast array of possible injuries that can be caused by CPR to that region of the face.
Professor De Fleur?
I'd agree with that. I'd also like to add that, of course, as a 10-month-old baby, there's entirely the possibility of the baby in some way using fingernails and similar to cause injury to any part of the body. And I think it's fair to say that such injuries are not at all uncommon in both living and deceased babies.
Thank you. Professor Cordner, do you have anything to add?
No, as Dr. Carla said, there can be a vast array of injuries resulting from mouth-to-mouth and cardiopulmonary resuscitation.
Thank you. Coming back to the autopsy, if we move down to the thoracic cavity, we have both lungs showing focal areas of collapse of a geographic pattern.
Yes.
What does that mean?
Well, we've discussed collapse and what it means, I think, before, but I'll briefly. The lungs don't collapse like a burst balloon. But what can happen and does happen is that little areas, little groups of air cells can partially close down for a variety of reasons. And if these occur, the lung, you've got lobes in the lung, you've got little lobules, you go down to segments, and then you go down to lobules. So you've got the potential for a geographic pattern to appear at various points in the lung of this, resulting from this collapse concept. Commonly seen at an autopsy, irrespective of cause.
Sorry, with your hand,
Sorry, it's commonly seen at autopsy, irrespective of cause of death. It's not a specific indication of anything.
Thank you. Now, there was an occasional petechial hemorrhage present.
Yeah, there's a typo there too. There's a very occasional petechium. Delete mesentery, that should not be there.
What shouldn't be there?
Mesentery, mesentrey. That's a typo that's escaped my eye.
That's further up. The fourth item just under the both lungs. Do you see that?
Occasional petechial hemorrhage present, yes.
So
Again, this is part and parcel of the second reference to petechiae. There were petechiae present on the surface of the lung. There were petechiae present on the surface of the heart. There were petechiae present on the surface and the substance of the thymus gland. There were no petechiae, and this is a very important point, There were no petechiae observed in the neck, the cheeks, the eyes, inside the eyes. The petechiae were confined to the contents of the chest cavity.
Now, that's a matter that was referred to in the SIDS definition that I took you to yesterday.
Yep.
That those type of hemorrhages located where you have located them is not diagnostic of SIDS, but it supports it.
The presence of petechiae confined to the chest cavity is certainly supportive of the diagnosis of SIDS. If I see them outside the chest cavity, I begin to have
That's the problem.
concern that the diagnosis is not SIDS. Although people have challenged that as well.
Yeah, thank you. Now, then moving down, there was the usual cribriform multifocal propatencies. What are they?
Right. The heart of the young child, as it is in adult, is divided up into 2 upper chambers, 2 lower chambers. The wall, if you like, between the 2 lower chambers in the adult is usually pretty solid. You cannot pass probes through it. The wall dividing the 2 lower chambers of the heart of the infant, one can frequently pass probes through it. You can't see these little passageways with the naked eye, but if you take a probe very gently, making sure you're not creating the passage, you can demonstrate passages, multiple passages through this wall. What's the significance of them? They're an anatomical feature that are there. As far as I know, no one has ever linked them to any clinical disorder of heart rhythm or heart function.
Thank you. Just turning over to the next page under the abdominal cavity, you say that the stomach contained a moderate quantity of curdled milk.
Yes.
Question mark egg white. What did that tell you?
Well, I looked at, what does it tell me?
Yeah.
Yeah, that sometime prior to the child's death it had consumed milk and possibly egg, and that's all it tells me.
Doesn't help you with when the child might have consumed it?
No, except that it was obviously alive when it consumed it.
Thank you. Now, turning over to the next page, you've got the pathology summary.
Yep.
And I think we've discussed 1, 2 and 3. Now 4, you've got a congested question mark.
Yeah.
Can you describe to us what you saw?
Yeah. If you stand in front of a mirror, open your mouth wide enough, look at the back of your throat, you'll see a little thing hanging down, and that's from the palate, and that's the uvula. You can't see it, but further down you've got the larynx, and guarding the opening of the larynx you've got a cartilaginous structure called the epiglottis. Now, in the adult, the uvula and the epiglottis are widely separated anatomically. That part of the respiratory tract of an infant is much more crowded. The spaces between these various structures are much, much less. In Sarah's case, the uvula looked a bit congested. More importantly, when I saw it at autopsy, and this was after the neck organs had been removed from the overall body, the uvula overlapped the epiglottis. And at the time, and still to this moment in time, I cannot be certain that this was not a post-mortem artifact that had happened because of the removal of the structures from the body. However, there is an alternative, and that this was real. Now, I had never seen this before. I had never seen this described in the literature before. So I was certainly at the time of the trial, I was not prepared to add any greater significance to it than that which I've just described to you. However, in a last-minute trawl of the literature, I discovered a paper which describes more or less exactly the same thing by someone else. So, all right, this is my vast series of one case, someone else's vast series of one case. What significance do you lay to it? Well, it's mildly supportive that this may not have been a post-mortem artefact, may have been real, and the other significance of this is there is a description somewhere about Sarah, but just before she died, or the night before she died, or something like that, of snoring. Now, it is possible, and I put it no more than that, it is possible that the snoring was because this uvula was bouncing off the epiglottis or bouncing off the larynx in the region of the said epiglottis.
You describe it as hemorrhagic. Are we to take from that that there was any bleeding or reddening of
Well, it looked red and bleeding. On a microscope, there wasn't so much evidence of bleeding. There was some physical evidence of inflammation on the pharyngeal aspect of the uvula.
By
So,
inflammation, it was slightly reddened. Is that how?
Redness is a sign of inflammation. Yeah,
I'm asking you what you actually saw and then thought of as inflammation. Was it reddened?
there was redness. Looking at it microscopically, there was evidence of inflammation.
Thank you.
Cellular evidence of inflammation.
Dr. Carla, do you have any opinion to give on the significance of the description that Professor Hilton has given of the uvula in relation to cause of death?
I don't think it's got any bearing on the cause of death. I agree with Professor Hilton that it might represent an artefact. He's described that. I agree with that. There's no photographs of it, so I can't actually look at it at the uvula myself, but I can imagine in a small child with tonsils enlarged at the back of the throat and a narrow airway that the uvula might be displaced or be a little bit elongated and from time to time touch the back of the tongue, maybe the epiglottis, and become inflamed just because of local trauma to that. But I honestly can't take it any further than that, and I certainly wouldn't say that, in my opinion, had anything to do with this child's death.
You said that the tonsils were enlarged.
No, I said I think I said if they were enlarged. It's usual in a child of this age to have tonsillar enlargement at the back of the throat, which are just two little areas of lymph nodes, which vary in size from usually about 1 centimetre in diameter each to even double that, and they can, in a small mouth and a small airway with a long uvula, be some sort of physical impairment to breathing on occasions.
Thank you. Your Honour, I notice time.
Yes, we'll adjourn for 20 minutes.
Professor De Fluke, Dr. Cutler, have you finished your answer in relation to the uvula?
Yes.
Thank you, Professor. Professor De Fluke, what's your view as to the significance of what Professor Hilton has described in his autopsy report as to the congested uvula?
I don't know.
Is that the extent of your answer?
It could be an incidental finding. It could be a cause of upper airway obstruction. But I think it is so rarely described and that I can't really get a feel for its significance.
Professor Corner?
Oh, look, it's a very interesting observation. It's interesting to hear Professor Hilton talk about it in relation to the snoring, and that sort of feels like it could have some cogency, I suppose. I think, and I wonder whether Professor Hilton really thinks this, that this is an interesting finding that perhaps, like some other findings that we might talk about shortly, puts Sarah into a slightly more risky category of infant, a bit more, how much more, who knows, a bit more vulnerable to SIDS.
What other factors are you referring to?
The other ones,
Yes.
or the histology factors, what we talked about before, some small signs of infection around some small airways, some very small signs of possible inflammation in the lymph nodes draining the lungs. So some small signs of inflammation in the salivary glands, interesting changes in the muscle fibres of the diaphragm. So even collectively, they don't sort of add to anything close to what I would regard as a cause of death, but it sort of shows that at some sort of level there is abnormality.
Well, we know she had a cold. Wouldn't all of that be accounted for by having a cold?
Well, yes, and it may be that a cold makes you more vulnerable to SIDS, as you know, as we've already discussed. It is thought to be, by some at least, part of the background to sudden infant death syndrome.
I took you yesterday to your report where you said that the presence of an inflammation like a cold was now a less consistent finding than it had been before in relation to SIDS.
Well, I'm reporting what the literature says. And I also said that in my mind it's still part of the story of SIDS is that a number of infants have a preceding mild viral-like illness, and whether that renders the infant, somewhat more vulnerable to whatever has led to the SIDS in a particular case is, of course, the unanswerable question.
Because it's certainly not the case that she died of the cold or the virus, is it?
No, and you need to be just a little bit careful about saying, oh, you know, you couldn't possibly die of a cold. I mean,
I said you're not saying that she died of the cold.
I'm not saying that, but I don't think one should sort of say that this is of no significance. You know, you shouldn't say, oh, just a cold and therefore could not possibly have any significance. That is not the case. It is the case that it is reasonable, and many people think that something like a cold introduces a vulnerability of that child to whatever the SIDS is.
A vulnerability to a cause of death we can't explain. Is that right?
Yes.
She's had no chronic illness in respect of respiratory in her short life, had she?
No.
Excuse me. Is there anything more you want to say?
No, just I hope you're all right.
Perhaps you're trying to, you might worry her about the significance. You might be worrying her about the significance of a cold.
I'm past the SIDS age. Thank you, Your Honour, for your concern.
Well, just keep her away from me if that's the case.
Is there anything more you want to say about cause of death in relation to Sarah?
Well, no, I notice the cause of death has been given as SIDS, and it seems reasonable to me.
I don't think I've asked you, Professor De Fleur, as to cause of death.
My view is that it is best described as a SIDS Category 2.
And why is it a Category 2?
Category 2, on the basis of age, so that's greater than 9 months. There is an autopsy abnormality described of the upper airway, the significance of which is uncertain, and that there has been death of siblings while in custody of the same caregiver.
And how does that factor in?
It's a definitional requirement.
I understand that. The definitional requirement is the fact of the death. What I'm asking you is how that contributed to your thinking about cause of death.
I think a central difficulty that I have is, do you consider these deaths each separately or together in combination? And I think both areas are issues to worry about. Certainly in the past, they would be considered together. But I think there's been a move towards considering these cases separately.
If you considered Sarah in isolation, would she be still classified by you as a SIDS 2?
Yes.
And if you
And that is on the basis of age and uvula.
And would you consider her a SIDS 2 death, taking into account now Patrick and Caleb?
Yes, I would, because it fulfills the criteria.
Fulfills the criteria, but that's a different question as to how you weight it. I mean, it's not a tick box thing, is it? To determine the cause of death, it's more complex than that.
Well, it's certainly more complex than that. In this case, looking at the infant, there is nothing going against a diagnosis of SIDS on the basis of autopsy. There's nothing going against SIDS on the basis of the circumstances surrounding the death as provided. And in a situation like that, I think it's entirely fair to give that as the cause of death.
But 2 of her siblings have died.
I accept that.
How do you take that into account?
You take it into account by including it in the cause of death statement, effectively.
Understand that as a matter of fact, you write down that 2 other children had died in the family, but that doesn't answer my question as how you consider it as an intellectual exercise, how this affects what you're doing in relation to cause of death.
Oh, look, there's no doubt I would worry about it. I would hope there is a detailed investigation associated with the autopsy. I would hope that I have done...
Sarah's autopsy.
Yes, with Sarah's autopsy. And that might extend backwards into a review of the other cases as well. If I was only aware of Sarah at this stage, and I had not been aware of the other 2, I would certainly go back to those other 2 as well and have a look at what was found, what was not found.
Would you take into account in your review of the previous cases Sarah's death?
I'm sorry, I missed that last word.
Would you take into account in your review of the previous cases Sarah's death?
Well, yes, you would. Because I wouldn't be reviewing the cases unless Sarah had died, would I?
Well, the question is whether you review the completeness of the autopsy and the like, and the cause of death in relation to each as a element of the whole, that is, whether each was done properly. That's one part of the review. The second part of the review is whether you would look through a different lens in respect of each of those because of Sarah's death. It's a separate exercise.
I'd certainly look at them with heightened concern, but I would not look at them with attempting, for example, to show that this is a homicide.
What would be your concern that had been heightened by the other deaths?
I would be concerned, is there a possibility of there being external agency in causing the death? And smothering would be an option that I would have to consider.
And you couldn't exclude smothering in relation to any of the three deaths, could you?
I couldn't exclude it, but I can't include it either. There's no evidence for it.
You wouldn't necessarily expect it either, would you?
Becomes a matter of, as there are more, I think you'd have greater likelihood
Of what?
of there being signs of smothering.
Why is that?
Because signs of smothering are not, I think, as shown by the work of Professor Cordner, that uncommon in babies. And if that's the case, you'd certainly worry about it. You'd expect over time, let's say there were 20 cases of smothering.
Now, let's just stick with the three we've got, Professor.
Okay.
Why would you expect, if each of the children was smothered, why would you expect the second to have more signs than the first and then the third to have more signs than the second?
No, that's not what I said.
Would you expect that?
I said there is, in every case, a possibility of signs of smothering. So to have none in all three cases, you've certainly got to wonder why this isn't the case.
Well, you indicated earlier that you would expect to be more likely in the later deaths that there would be smothering.
No. I think I might have explained it incorrectly. What I'm saying is the more cases there are, the more likelihood of one or more of those cases showing signs of smothering.
Why?
Now, because when a person is smothered, there's a possibility of signs of smothering in any case. So in three cases, there would be the possibility of signs of smothering in three cases. So if you like, you treble the likelihood.
You weren't interested in statistics before, I think. Professor, I suggest you think about whether you want to engage in a statistical analysis of this, but
That's not a statistical analysis, I believe. In each case, you have, let's say, let's use as a number.
Three. Use three as a number.
Yeah, well, three cases. Now, let's say in each case there was a 1 in 2 chance of there being signs of smothering.
And where do you get the 1 in 2?
I'm saying, let's say.
No, I'm not interested in let's saying, Professor. If you're wanting to give evidence about this, you need to indicate the basis upon which you're saying there is a 1 in 2 chance of there being signs in smothering.
I think Professor Cordner's examination showed 40%, did it not?
You'd have to refer me to his report if that's the source of it, unless Professor Cordner can help us with the page of his report. Would you like to proceed while that's happening? Would you like to wait until it's found?
I'll wait.
Can you help us with where it is in Professor
No.
Cordner's report? Do you have a copy of it in front of you?
Page 52 has some of that material.
Thank you.
Thank you.
Now, where is it that you're referring to the 40% or 1 in 2?
Are you asking me?
No, I'm asking Professor Defoe.
I'd like to emphasise, number one, that I do not state that in Professor Cordner's report there is 50%. I said, say 50% for the purposes of this calculation. Nevertheless, Professor Cordner does indicate that 6 or 55% of cases had general and or specific signs of smothering. So I'd argue that 50% is a fair approximation.
So you're referring on to the searches that had been undertaken since 2000, 19 years ago. Is that the data you're referring to?
I am.
And so you're saying that this supports, you'll have to just tell me again what that was, Professor. This supports what?
Well, what I'm saying is I was trying to use or to show why the more cases there are, the greater the likelihood of overall seeing an injury. Now, in 50% of cases, can we accept 50%? Because my maths will probably fall apart unless I use 50%.
It's your evidence, Professor.
Thank you. In the first case, there is a 1 in 2 chance of there being signs of smothering. In the second case, there is a 1 in 2 chance of there being signs of smothering. So we now have 1 in 2 and 1 in 2. In the third case, there was a 1 in 2 chance of there being signs of smothering. That is now, in 3 cases, there is a 1 in 2 chance in each. I think that would indicate that there is, as the number of cases increases, the chances of finding signs of smothering or any other condition increases overall. It doesn't increase per case, it increases in the overall.
So your evidence is in relation to the 3 cases so far, we'll leave Laura to one side for the moment, that the fact that there was no evidence of smothering in Patrick and then in Sarah means that it's less likely they were smothered. Is that your proposition? Because you would have expected more likelihood of signs in Sarah than Patrick. Is that your evidence?
I don't know if you can argue the reverse. What I'm saying is that there were no signs of smothering in any of the 3. And what we know from that work conducted by Professor Cordner is you see it in about half the cases.
Just to be clear, Professor, your evidence is that the fact that there were no signs of smothering in Patrick and the fact that there were no signs of smothering in Sarah means it's more likely rather than less likely than they were smothered because of your expectation based on your 1 in 2. Is that right?
I'm sorry, I don't follow that reasoning.
You don't accept that?
Could you do it again?
Your evidence is that because of your statistical analysis of 1 in 2 times 3, that it's more likely that there would be signs of smothering in the latter 2 children. And therefore, do you conclude that the absence of those signs make it less likely that each of them was smothered?
No, I did not say that to the first part of that proposition. What I have said is in each child, there are no signs of smothering. If it is accepted that signs of smothering are seen in about half of the children who are smothered in any size population, then the larger the population, the more likely the greater the likelihood there will be of picking up any smothering in any of those cases.
So your evidence is not related to 3 cases within the one family, it's more broadly based, is that right?
Effectively, yes.
Dr. Carla, do you have anything to say about your opinion as to whether or not there's evidence of Sarah being smothered?
There isn't absolute proof of smothering. I've mentioned some.
Sorry, there is or?
No, there is
isn't,
not
thank you.
absolute proof.
Thank you.
Is
Is that all you want to say?
I just wanted to add that there are, however, some marks about the lower lip and the chin. I'm not certain of the cause of those. I don't want to elevate it and say they indicate smothering because I don't believe they do. But they can be explained in a number of ways. But any marks around a child's mouth and face generally in a deceased child are of concern and raise the question of how did those marks come about. And I think both Professors DeFlew and Hilton have talked about innocuous injuries and CPR, and I accept all that.
Do you share the view that in relation to the second and third child, it would be more likely to expect signs of smothering if they indeed were smothered? Do you accept that?
No, I don't, and I don't follow that
Thank you.
reasoning.
Can I come to the findings on the histology or the microbiology? You referred to them earlier, Professor Cordner. I just need to have them on the screen. Know where they'd be found? Tabs 33A and 33B. Now, this is what I think you were referring to earlier, wasn't it, Professor Cordner?
Yes.
Professor Hilton, is there anything you can help us with as to the meaning or consequence of there being profuse coliform and the various other matters referred to in this document?
Yeah, we've discussed the significance or lack
Yes.
of coliforms of any shape, size or form found at post-mortem.
Is this the same as your answer in respect of Patrick?
Yeah,
Thank you.
I mean, it's a curse upon the interpretation of post-mortem microbiology, irrespective of this case or any other case.
Thank you. Dr. Carla?
I'm sorry?
Dr. Carla?
Did I haven't seen that document for some time.
Take your time to have a look at it.
What I'm seeing at the moment in miscellaneous, so I'll go to virus. There's no virus, it's isolated. So I'll go to miscellaneous, and the lung cultures showed a mixed growth of bacteria. Mm-hmm. The spleen showed moderate coliforms, which are gut organisms of 3 colonial types. So again, mixed. And then the final report from the large bowel, large intestine, again showed a mixed range of organisms. And I can't quite see the last one or down the final. Thank you.
Let me scroll up the document. That's it?
But the small intestine also showed profuse coliforms of 2 colonial types. In my opinion, they're contaminants. I wouldn't put any weight on those results. They're mixed organisms.
Thank you. Professor De Fleu?
Look, my comments apply from our previous discussion concerning, I think it was Patrick. There is one aspect here which is somewhat different. The first one is that the lung tissue was, it says, collected and received on the 31st of August, while the other specimens for microbiology were collected and received on the 2nd of September. I would think that the collected on the 2nd of September is quite unlikely, but possibly Professor Hilton can inform us. But a receipt of the specimens only on the 2nd of September would suggest that there's been a prolonged interval between taking of the samples and the specimens arriving in the laboratory for further processing, which is not ideal.
What effect does that have?
The major effect is that you can have contamination and overgrowth of organisms.
So that supports each of your view as to they were contaminants?
It certainly raises that as a greater possibility, yes.
Can I come to Dr. Blackwell's report, or Professor Blackwell's report, for a moment? And Dr. Carla, you'll be aware of this from having read her report. She particularly refers to you, and this is her first report, and I'm on page 2. I just want to give you an opportunity to respond to this. Paragraph 9. She refers to various mediators used in research, and that the tests were important in assessing if a child had an inappropriate or overwhelming inflammatory response. And then 2 reasons for not including these tests are additional costs, and the role of infection and inflammatory responses is not widely held to be important. And then she attaches a letter, which is attachment C. If we could have attachment C to her report up. You've seen this before, Dr. Cullen. It's been brought to your attention.
Yes.
And this is a letter from the Solicitor for Public Prosecutions to Legal Aid during the course of preparation for the trial. And this is in relation to Sarah. And the third paragraph is that you advised that the theory associating the IL-10 gene with SIDS is nothing more than a theory, and it's not accepted in the forensic community. Excuse me. She might just read that for me, Dr. Carla.
Out loud?
Yes.
Dr. Carla advised us today that the theory associating the IL-10 gene with SIDS is nothing more than a theory. It is in no way accepted by the forensic community or other people generating the medical literature around the world. He does not give the theory any credence. It is just a theory at this stage.
And then the next paragraph.
Dr. Carla stated that anyone can go fishing for a gene and suggest a genetic link with SIDS. The issue is whether or not the theory is accepted by the wider medical community. Dr. Drucker is a microbiological researcher. This theory has not been accepted by the forensic or SIDS people at all. Dr. Carla regards it as inherently dangerous when a researcher refers to a gene in this situation as the so-called cot death gene. He regards a theory which associates the IL-10 gene as a vague theory by microbiologists. At this stage, it is no more than junk science.
And is it the view that you stated around about that time?
I didn't agree that the IL-10 gene would be considered or accepted as a SIDS gene. I didn't say, and I don't believe I said that it was junk science, but I said that words to the effect that we have to be careful in all aspects of medical research and medical investigation to make sure that what is permitted as valid conclusions from research is done in a proper way, under proper conditions, and is valid, rather than accepting a theory because it might sound plausible, but in fact with retesting and attempts at revalidation simply isn't done. So I wasn't suggesting that Dr. Drucker and anybody else attached to this was junk science, but I was flagging caution in interpreting this in relation to Sid's deaths.
Now, in 2019, do you have a view different from the view that you'd expressed in 2003?
No.
Thank you. Now, unless anyone has anything more to say about Sarah, yes, Professor Cordner.
I'm looking at chapter 25 of Bayard's huge tome,
Yes.
and natural diseases causing sudden death in infancy and early childhood.
I think you have our copy.
You can have your copy.
Thank you very much, Professor. Sorry, what page?
So it's page 548.
Thank you.
And I just would like to read, and this is a chapter by two doctors, one with an MD from Great Ormond Street, which is the UK's premier paediatric hospital. And this is in a section listed respiratory tract infections, and in particular lower respiratory tract infections.
Is this acquired
And
respiratory conditions or the...
in the last paragraph, just before respiratory papillomatosis on page 548,
Yes.
I'd just like to read, it's about 8 lines. Do you mind?
Certainly.
Diagnosis of lower respiratory tract infection at autopsy is based primarily on identification of significant airway or airspace inflammatory cell infiltration with or without positive microbiological findings. It should be noted that there is some controversy regarding assessment of severity of such changes and their relationship to the cause of death, with some providing lower respiratory tract infection as a likely cause in all cases in which any definite evidence is present, whereas others may interpret the findings as present but insufficient to explain the death. At present, until further gold standard tests are available for evaluating mechanisms of death, definitive determination of clinical significance remains impossible. I'd just like to say that in this particular case, the lung cultures do show Streptococcus pneumoniae and says copious or some word that describes a large growth. That is a pathogen, and as was explained yesterday, we pathologists like to see the actual inflammatory signs in the lung indicating infection, and the effect of the work of people like Professor Blackwell is searching for these other tests that might indicate significance of positive culture results like this one, where there is minor or no actual evidence of infection that we can see down the microscope. So I do think it's a little bit not right to dismiss completely that the possible significance of the culture results in this case, the very minor, mild signs of infection, plus an opinion that says they are significant. I think you've just got to keep open the possibility that there is something there. I personally am not dismissing that.
Are you suggesting that some of your colleagues are dismissing it?
Well, when I heard junk science, I thought that included this sort of thing.
That was more about the gene IL-10, as I
Okay,
understand.
well, if that's the case, then
That
I've
was
heard
mainly a
wrong.
reference to Dr. Carla.
Well, I heard the reference to junk science, and if it's about the genes, well, we can have another discussion about that. I just wanted to make sure that it was clear that the sort of things that Professor Blackwell is talking about isn't in the zone of junk science. So just make sure there's no confusion about that.
Professor Hilton, just coming back to this paragraph which is on the screen, you did not make, as I understand it, a diagnosis of LRTI at autopsy, did you?
Not in these terms. I think there were, from memory, small areas of inflammatory infiltrate in the lungs. Would I classify that as a lower respiratory tract infection?
You didn't on the occasion.
It probably is taken back to its basic. Would I think it's of clinical significance? Well, it's there, so it's probably. But I don't think this kid had a coughing, horrible, low respiratory cold. It may have had the makings of. Sarah might have. But at the time of her death, she had some signs of minor signs of focal respiratory tract infection in the lung. Now, these would not occur. These signs would not occur as a post-mortem artifact because there's a cellular infiltrate, cellular exudate. That ain't going to happen post-mortem to any great extent. Basing it on the presence of post-mortem cultures, I think would be a leap of faith which I would not be prepared to take.
Thank you. Dr. Carla, was there anything you wanted to say in response to Professor Cordner's comment? No. Thank you. Well, leaving Sarah now, can we turn to Laura? Now, Laura was born on the 7th of August 1997 and died on the 1st of March 1999. She was 18 months and 22 days, and like her siblings, she was full-term, not underweight. Her mother did not smoke. She was 30 years of age, and Laura was found on her back with her face uncovered in her own bed. There were no signs of neglect, and the family was not socioeconomically disadvantaged, and her father smoked outside. She was vaccinated and used a dummy, again, query how often, and she was breastfed for 2 weeks. 12 days after Laura was born, she underwent full biochemical, blood and metabolic investigations, which were normal, according to the person who conducted them. A sleep study showed mild central apnea and no obstructive apnea, which improved on subsequent studies, and Dr. Seaton, who undertook them, said in a statement that she was totally normal by February 1998. Laura was monitored by a chorometric home cardiorespiratory monitoring device, which was designed to record and download breathing and heart information during her sleep. She was monitored for about 12 months without complication, according to the doctor. And the doctor also said that the monitoring showed no serious breathing problems or heart rate problems, the only problem being that Laura was not monitored during all her sleeps. And Dr. Seaton, in his statement, noted that when he saw Mr. and Mrs. Folbigg on 30 April 1998, it became clear that the monitoring was becoming tedious, relating to the number of false alarms, technical difficulty and the like, and taking a very precautionary approach in an apparently healthy baby. It then appears that the monitor was used less after the first 6 months. Dr. Paul Innes was Laura's treating GP, and over the 6 months he saw her, she was a normal, healthy child with no chronic illness. Dr. Cash was a visiting medical officer at Singleton Hospital. He examined her several times with a history of a slight upper respiratory infection over several days and a croupy cough. That was in June 1998. And he found no signs of distress or respiratory difficulties. Now, if we can have up tab 46, which is the report of the death to the coroner, and while that's coming up, does any person wish to say anything more, leaving aside the cold she had 24 hours before she died, which I'm coming to, about Laura prior to her death? No? 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 So this is the report of the death to the coroner. Now, if we can just scroll down. There was, on this occasion, a death scene investigation checklist that was conducted and completed. If you can just scroll down further for me. It's at the end of it. So keep turning over the pages. This is mine. I need mine. There's reference on what is page 133 at the bottom. Excuse me. There's in the third paragraph to on the 1st of March, the child having woken, suffering from flu or cold symptoms, which had plagued her for the previous 7 days. And it was noted that she'd been given Demazin on the 27th of February for those symptoms. And the mother stated that the child was in a bad mood or although not seriously ill. Now, having completed that, can we then come to the ambulance reports? Which is tab 51, the officers who attended at 12:14 p.m. described her as warm to touch, and the report records her skin temperature as normal. By contrast, Ms. Folbigg had said that Laura was cool, although not cold, when she found her. Now, turning to the autopsy at tab 47, Dr. Carley, you completed the autopsy?
Yes.
And Professor Hilton, you were present for some or all of?
I have no exact personal memory of this, but I would accept that I was there, and I was there a substantial amount of the time.
Substantial.
Substantial.
Thank you. So this is the interim report, and Dr. Carley, you've given the direct cause as undetermined. Now, it's a very brief interim report. What was the purpose of it?
That goes to the coroner's office and basically allows the body to be released, or if it's kept on hold, informs the coroner that the body has been kept on hold for possible re-examination or further testing or whatever.
Thank you. If you can scroll up, you've ticked that significant injuries were not present.
Yes.
Then if we can go to tab 54, which is the final autopsy report. Now, scrolling down this document, you might take us through it, Dr. Carla, as to what's the significant aspects of it, beginning with the time of autopsy being 9 p.m.
Yes.
And then after that?
It's not mentioned who else was present, but there was a crime scene officer from police, Clint Nichol, and as Professor Hilton has said, he was also present. My recollection is, as he said, for most of the autopsy, if not all.
Would you like a hard copy?
No, I'm fine.
Thank you. Right, keep going, page 2.
So, as you can see, up the top is my opinion as to the time and date of death. I've said sometime between approximately 11 a.m. and 12:45 p.m. on 1st of March 1999 at Singleton Hospital, which is when life was pronounced extinct.
Mm-hmm.
And I've said cause of death undetermined.
Which was consistent with what you'd said earlier.
Yes,
And then you'd give a report, summary and opinion.
yes,
And in relation to Caleb, Patrick and Sarah, am I correct in saying there's nothing there that we haven't already heard about
that's right.
over the course of the last 2 days? And then you turn to Laura,
Yes,
and at the end of that paragraph beginning with Laura, you say the father of all the children has allegedly been diagnosed with obstructive sleep apnea. What was the source of that? We need to follow 168, the paragraph beginning the fourth child.
my memory is that this was information from medical records from Westmead Children's Hospital.
And why do you use the word allegedly?
I don't know that it was absolutely proven. That I remember that there were notations that said Craig was a snorer, or words to that effect. So it was suspicious for obstructive sleep apnea, but I don't know that he ever had formal testing for it in the way of a sleep study to properly diagnose it.
So effectively, you were referring to him snoring.
Yes.
Thank you. Now, if we go over the page to 169, you describe the post-mortem examination.
Yes.
You say that there were no significant injuries externally, apart from minor bruises to the lower limbs.
Yes.
Did you attach any significance to that?
No.
You then say there were no injuries to the face or in the oral cavity,
Yes.
and then you refer to there being no particular hemorrhages on the face or on the eyelids.
Yes.
What significance was that to you?
I think we've discussed the presence of particular hemorrhages on the face of being of concern but not of being diagnostic. So I had to note that there were in fact no particular hemorrhages.
And you re-examined the area the next day?
Yes.
As usual?
Is it usual?
Yeah.
No.
Why did you do it?
Because I was quite concerned about this child's death. As you can tell, I had, even at the interim level, following the autopsy, I had no clear-cut cause of death. And I wanted to be thorough and detailed and re-examine the child.
Because you obviously knew about the 3 other children.
Oh yes, I was told that immediately. I was informed of that Laura's body was coming to Glebe for an autopsy.
You were told before you saw Laura. Is that what
Yes, I was told that.
Thank you. Now, you refer to internally there were no significant abnormalities apart from... I'm losing my voice. I'm going to have to ask you to read that out, Doctor. Apart from...
Oh, internally there were no significant abnormalities apart from focally hemorrhagic and collapsed lungs.
And that is of...
It's a non-specific finding. We've been through that in other cases.
And the next paragraph?
Yes. Histological examination of tissues showed an inflammatory infiltrate in the heart, consistent with myocarditis of probable viral origin. This accords with the history of a cold/flu-like illness for several days prior to the death of the child. There are a variety of causes for myocarditis, including some viruses, bacteria, fungi, some immune-related disorders, some drugs and several other causative agents.
Well, we'll come back to the myocarditis. And you noted in the toxicology examination that the demazine, which Laura had taken, was not present.
Yes.
Therefore, she hadn't had it for some
That's
12 to 24 hours.
yes.
Thank you. Now, leaving aside for the moment your commentary at the bottom of that page and coming to the autopsy findings themselves, if we can, that's on page 171. If you can perhaps draw to our attention any matters of relevance to you that we have not covered from the earlier comments. So it seems to me that there's nothing
I would agree with that.
on 171. And 172, there's evidence of bruises. You didn't attribute any significance to those.
That's correct.
And then on 173, is there anything there that we haven't already discussed? You consider relevant?
No.
No?
No.
And then moving over to 174, which I think is in the same category, and then to 175. There's nothing before then you wanted to raise, Dr. Carla?
No.
And then on 175, you referred to having performed a facial dissection.
Yes.
Is that usual?
No.
Why did you do that?
I wanted to specifically look at any possible injuries to the child's face and particularly around the mouth, and that's not easily done by just lifting the lips up or down. Pathologists perform this, I wouldn't say routinely, but on certain occasions where it's important to look for the possibility of injuries that might have some forensic significance.
What did you find?
I didn't find any.
What conclusions did you draw from that finding?
Didn't draw any conclusions.
Now, coming to the microscopic examination of tissues, which is further down that page, you describe the heart, and I might ask you to read that first sentence.
Within the myocardium, which is the heart, is a moderately dense infiltrate of lymphocytes which have aggregated in certain areas, particularly subendocardially and along the superficial surface of the myocardium, although further sections show large aggregates in the central area of the left ventricle.
Are the next two sentences relevant for the appearance of what you saw?
Yes.
We'll read those then.
In these areas, there are large clusters of lymphocytes surrounding degenerate myocytes. Myocytolysis is present. No viral inclusions are seen.
And the appearance.
And then the appearances are of myocarditis, which is probably viral in origin, in etiology or origin. Sorry.
Thank you. This is on microscopic examination.
Yes.
You looked at the heart with your eyes. Did you see anything?
No.
Thank you. And is this the first time you recorded in writing what it was that you saw microscopically in relation to Laura's heart?
Yes.
And you recorded it fairly close in time to having performed the microscopic examination?
Yes.
Turning over the page, there's reference to widespread hemorrhage in the lungs.
Yes.
Is that of significance?
No. pardon me, I'm losing my voice as well. No.
Thank you. Now, they were the autopsy documents. There are no additional documents, are there?
That is the report.
Yeah, thank you. Now, on more than one occasion, you have had the opportunity or burden of describing what you saw microscopically in relation to the heart.
Yes.
That's right.
Yes.
And I'll just take you to some of those, and you can tell His Honour your current views. Now, in a number of pieces of correspondence, you describe what you had seen, and perhaps if we can come to tab 61. This is a letter you wrote to Detective Ryan, who was involved in the investigation. And you were asked a number of questions, and if we can just scroll up. And the answer to the first question is whether or not you performed staining for hemosiderin-laden macrophages. And you did, I take it.
Yes.
That was a negative result.
Yes.
And I think we heard yesterday that there is certainly some views, particularly by Professor Berry, that the presence of that may give some indication as to potential smothering.
Yes.
And you didn't find it.
No, I didn't.
Okay. Continue going up, scrolling up. On page 211, under question 5, you were asked questions in relation to your finding that it was an incidental finding. Do you see that?
Yes.
And then you described the inflammatory infiltrate as light in amount and patchy in distribution.
Yes.
Now, is that consistent with what you had said in the autopsy?
No, I've described it as moderate, up to moderate, but I accept that there is a difference. I've said light and patchy, up to, in my report though, I said moderate. So there appears to be a discrepancy. So what I say is that in areas of examination of the heart, in particular the left ventricle, the inflammatory infiltrate was light and patchy. In other words, it was small in amount, a small number of lymphocytes aggregated around the cardiac cells, but it was accentuated in areas, as I've described, in portions in the middle of the left ventricle, to put it up to moderate, to put it up maximally to moderate intensity. So if I could just say that pathologists often describe things, for example, the amount of infection or tumours as being mild, moderate, severe in amount or intensity. So in this setting, I'm describing a mild form of inflammation where I've described light and patchy in amount and patchy in distribution, but in areas there was a worsening of that inflammation to a moderate level of inflammation.
So
at best, it was moderate in intensity.
at best. By best, do you mean?
At its most severe.
So these two statements sit together, do they, as opposed to inconsistently, because you're referring to different places? Is that how to understand your evidence?
Yes, and also, can I say this letter was written 2 years after the final report, and I don't recall that I went back to the autopsy report to exactly see what my terminology was, but I accept that I've referred to this as being light in amount and patchy in distribution, and overall, that remains my view, but there were areas where the inflammation was more severe.
As you say, this was written 2 years afterwards, and the autopsy report was written more or less contemporaneously,
Yes.
having viewed the slides.
Yes.
I take it, therefore, that the most likely case that your view is better expressed in the autopsy report than in this letter.
I would say so, yes.
Your Honour, convenient time?
Yes, we'll adjourn till 2 o'clock. Yes.
Thank you, Your Honour. Dr. Carla, I was taking you through tab 61, which was your letter dated the 19th of June to 2001. If we can have that back up on the screen. I asked you questions about your reference to light in amount and patchy in distribution, which we dealt with. And then if we can continue on in that paragraph, which is on the second page, you refer to your opinion, and perhaps can I ask you to read that from my opinion onwards in that second paragraph?
My opinion that the inflammatory infiltrate in the heart represents an incidental finding is not based on the family history, but rather after consideration of the history provided of Laura's very sudden and most unexpected death, the post-mortem findings of Laura, and the histological assessment of the heart, together with my own knowledge and experience of the condition of myocarditis.
So it was suggested to you, was it, that you may have taken the family history into account in determining whether there was myocarditis or whether it was an incidental finding?
My understanding was whether there was myocarditis present based on the family history, but to which I'd answer no. The myocarditis was a standalone diagnosis that I could clearly make microscopically. So not completely ignoring, in fact, the other three deaths.
All right. And so you then, in the next paragraph, say that in other cases you've seen where death's been due to myocarditis, the inflammatory infiltrate has been much heavier in number and more diffuse in distribution. Now, is that by comparison to your reference to light in amount and patchy in distribution
Yes.
above?
Yes.
Is that the same in relation to your finding in the autopsy that it was moderate in
Yes.
intensity? Applies the same?
Yes.
Because, as you indicated earlier, moderate does have a different interpretation from light and patchy, and you agreed that moderate was the more likely proper understanding you had because it was on the autopsy. So can you just turn your mind to it being moderate in density and what you've said in that paragraph I've just read, and tell me whether that paragraph applies to moderate as well as to light in amount and patchy in distribution?
I'll read it out. In other cases I have seen where the death of a child or adult has been due to myocarditis, the inflammatory infiltrate has been much heavier in number and more diffuse in distribution throughout the heart, although the amount of inflammation is variable from case to case.
So that applies to your autopsy finding of
Yes.
moderate?
Yes.
Thank you. Now, towards the end of the page, you say if you'd examined Laura's body in isolation, you might give the cause of death as myocarditis.
Yes.
Why might you do that?
Because I'd be cautious about giving an unequivocal cause of death based purely on a pathological finding, and I know that myocarditis is a potentially serious condition, but I would be cautious about looking at a slide or slides and without knowing anything else about the case saying that was unequivocally the cause of death. I would exercise caution in that case.
And then you indicate, excuse me, over the page, you cannot ignore any known relevant family history of severe illnesses or premature deaths. And then you go on to say that this is not to say, however, that such information in any way need bias or prejudice my opinion. Why are you referring to bias or prejudice in that context?
I wanted to point out that even though I knew of the previous deaths, I wanted to make the point that I looked at this case and these were my views that I expressed, but that I wasn't biased to express any particular view or prejudiced in any way. It was a finding that I determined myself just by looking at the material provided.
Well, we know the SID's various definitions requires you to look at whether there are other sibling deaths. So why would the question of bias or prejudice arise in any case, Dr. Carla?
I think I formed that sentence to try and paint the picture that I was looking at Laura objectively, but also looking at knowing the other three, but also looking at the other three objectively, without any person influencing me or giving me selective material that might in some way appear to bias or prejudice me.
Why would you look at it anything other than objectively, Dr. Carla?
I wouldn't. I would look at everything objectively.
So did somebody suggest something to you in order for you to go down this bias or prejudice path?
I don't recall that anybody did.
Did you have any connection other than in your role as pathologist with this family at all?
No. None whatsoever.
So you were doing your normal job
Yes.
and there were 4 children and you took into account the 4 children?
Yes.
Thank you. Now, further down, you're asked if so, what are the possible causes of death? And you refer to non-accidental asphyxia in the form of deliberate smothering must be considered as a possible cause of death. Now, was there any evidence of deliberate smothering on autopsy? Then what is the basis for your view that that must be considered a possible cause of death?
Given that there had been 4 deaths that I certainly knew about, I was not convinced that, or I'll start again, I was not satisfied by any of the diagnoses that I saw in relation to the first 3 children, and I wasn't satisfied myself that myocarditis purely, that it was the diagnosis to reach satisfactorily to explain Laura's death. So although I've said that smothering can leave no trace, and that's a possibility, I thought that in view of the fact that there are 4 deceased children, all of whom have died suddenly and somewhat unexpectedly, that that is non-accidental asphyxia in the form of deliberate smothering, I raised it as a possibility to explain Laura's death and possibly the deaths of the other 3 children.
Can I take you to tab 58, if we can have that on the screen? Now, this is a letter that you wrote to Detective Ryan in June 1999.
Yes.
And if we can go to the second page, the 3rd paragraph, just read out that first sentence for me, if you would.
This 4th child did not die of SIDS as she was too old for this diagnosis and had an intercurrent illness which might have explained her death.
What's the intercurrent illness?
The cold and flu-like illness with the myocarditis being present.
So the intercurrent illness is the flu or cold as the viral background to
Yes.
the myocarditis, is that right?
Yes.
And it was the myocarditis which might have explained her death.
Yes.
Thank you. Now, can I come to tab 56? And this is a statement you made to the police about Laura. And it follows your examination of a video in March 2003, and it was a video of Laura playing around in a backyard swimming pool, and the video was dated the 28th of February,
Yes.
which is it the day before Laura's death, on the 1st of March?
Yes.
Excuse me. And you indicate your observation and opinion of Laura as seen on the video in paragraph 3. Can you read that out for me? Sorry, that's paragraph 3 on the second page.
181.
Laura Folbigg appeared to be in good health and was well nourished. Her general development appeared normal for a child of her age. She responded appropriately when called and exhibited no evidence of a cough, shortness of breath, wheeze or other form of obvious ailment or physical impairment.
So, I'm sorry. And then at paragraph 7, you indicate that she appeared in such good health less than 24 hours prior to her death. And can you read out the rest of that sentence for me?
That Laura Folbigg appeared in such good health less than 24 hours prior to her death makes me believe more firmly that the myocarditis which was found at autopsy played no role whatsoever in her death and was an incidental finding.
Now, you had described myocarditis before as it might have been the cause of death.
Yes.
Here you're referring to played no role whatsoever, which is more emphatic. What was it that caused you to be more emphatic in your view?
I found the video to be important. As depicted, it showed a child who appeared to be in very good health, but who 24 hours or less than 24 hours later was deceased. She exhibited no outward sign of symptoms, as I've said in that, and so I was of the view then, based on the video, that it made it even less likely for me to be of the view that she's died of myocarditis.
Do you understand that people, including children, can die of myocarditis without showing any symptoms beforehand?
A small number can, yes.
Why couldn't she be part of that small number?
She could be part of that small number.
It's a very emphatic description, Dr. Carla, played no role whatsoever.
Yes, I accept that.
And that's still the view you hold today?
No, I'd temper that. I would say when I've said played no role whatsoever, that categorically excludes it as being a cause of death, and I think that's incorrect.
So what would you say today?
I'd say I cannot positively exclude myocarditis as being a cause of death. I did say that at trial, and although I believe it's, in my view, she did not die of myocarditis, I do not believe I can categorically exclude it as being the cause of death.
And you consider it to be an incidental finding?
That's my view.
Thank you. Now, at trial, as you say, you didn't exclude the possibility, but you said that you did not believe it to be a reasonable possibility. Is that still the position you have?
It is.
And you described it as quite patchy and rather mild, the amount of infiltration, and that it was not particularly heavy. Now, is that, to your mind, consistent with what you'd said at the autopsy?
Those are not the exact words used. When I said not particularly heavy, that's... it's not saying it's moderately heavy. It's different terminology, I accept that.
It's more than just terminology, isn't it? I mean, to say something is quite patchy and rather mild
Yes.
differs from saying it's moderate.
Yes, I agree.
And your view now is that what you said in the autopsy is the best evidence as to what your opinion was close to the time of the autopsy.
Yes.
Is that right?
Yes.
Thank you for that. Now, can I come back to all of you in relation to Laura? I think it's correct to say that each of you is of the view that Laura had myocarditis when she died. That's right, Professor Cordner.
Yes.
Professor Hilton
Yes.
and Professor De Fleu.
Yes.
And that I think you all accept that there may or may not be observable symptoms of myocarditis in a child before she dies. Is that right, Professor Hilton?
Yes.
Professor
Absolutely
De
the case.
Fleu? Professor
Yes, it's unexceptional. Unexceptional for a child to die suddenly and unexpectedly from myocarditis with no preceding indicators or indications or symptoms. As I understand it, Laura did have a bit of a sniffly viral sort of cold, but not that anybody thought was of any significance. So you can have that as either a preceding symptom or that actually it was completely and totally sudden and unexpected.
And each of you agree that myocarditis obviously can cause death. There's no doubt about that, is there?
Yes.
Yes. Yes.
It's an unexceptional, well-recognised cause of sudden unexpected death.
You say it's unexceptional, Professor Cordner. Do you accept that it's rare?
I don't think it's rare. I think it's uncommon. And just to, because we've mentioned it a couple of times now, it's in category 2 of Polanin's sort of categorisation of the sort of evidence strength for a cause of death.
So you say it's not rare, but it's uncommon. Is that right?
I think that, yeah. I mean, there's a long list of conditions that can cause sudden and unexpected death.
No, but we're talking about myocarditis.
Yes.
Professor De Fleu?
Look, in my view, it's one of the more common causes of sudden cardiac death in young people. In a study that we did some years back, it was the third leading cardiac cause of sudden natural death in Australians aged 5 to 35. Now, I accept Laura is not in that age group, but it certainly is a not uncommon cause. After saying that, death due to myocarditis is uncommon, but it's certainly seen, and I think it's certainly something that your average forensic pathologist will see multiple times over there.
You accept uncommon as Professor Cordner proffered.
Yes.
Professor Hilton?
Yeah. In the overall picture, myocarditis is perhaps an uncommon cause of death. However, there's another side to that coin. Are people with myocarditis subject to sudden unexpected death? And the answer to that is yes.
Now, Professor Bayard did a study that he referred to in the evidence he gave, and which identified a small percentage of children who had died suddenly and unexpectedly from myocarditis. Now, I take it from what you've certainly said in the past about Professor Bayard and his evidence to that effect, you'd accept that, Professor Cordner?
Well, can you tell me what he said?
Well, that's what he said. He referred to studies which identified a small percentage of children who had died suddenly and unexpectedly from myocarditis.
Yes. I mean, we can easily get you the numbers if you...
Do you take exception to what I've said to you from Professor Bayard?
No, I don't, no.
Does anyone else take exception to that? So then can I come to what each of you has ultimately said as to the cause of death. Now, Professor Cordner, if we can start with you, perhaps if we can have Professor Cordner's report on the screen. Thank you. At page 80. Now, it's the second last paragraph. And Professor, you there say that you believe the middle of the road conclusion in relation to her death considered alone, most forensic pathologists would be comfortable ascribing the death in similar circumstances to Laura's being due to myocarditis. And that's your view. You state in your report, and that's still your view?
That's still my view.
And then you say that it would have been acceptable and you would support a pathologist who gave the cause of death as undetermined, and in the comments section fully canvass the possibilities. Now, in saying that, you ultimately agree with Dr. Carla's determination as to cause of death, but you may well have said something different in the comment section.
Well, partly agree with that, I suppose. I disagree with Dr. Carla's reasons for thinking that death is not due to myocarditis. I mean, he has certainly gave a number of reasons at the trial that he believed indicated that meant the death was not due to myocarditis, and I don't think there are any reasons to suppose that the death is not due to myocarditis. So, but ultimately, so long as it's explicit, if somebody said undetermined and then was explicit about why they had come to that view, then at least we can have a discussion about those explicit reasons.
And you say in this paragraph that you'd support effectively Dr. Carla, who gave the cause of death as undetermined, and fully canvassed the possibilities, but because it was the fourth death in the particular family, there could be other factors, including but not limited to homicide.
So that meant including natural causes, but including homicide at work, yes.
And so by the time of the fourth death, that would be something that would be in your mind.
Yes.
Thank you. Professor De Floo, you, I think, effectively agreed with Professor Cordner that you would be of the view that it wouldn't be unreasonable to call Laura's death as undetermined.
It would not be unreasonable, but at the same time, I would be more than happy to give it as myocarditis. Yes.
And I think your report said that you believed that myocarditis can be incidental, but you also took into account that 3 siblings had died.
Yes.
How did you take into account the death of the 3 siblings?
Well, it's certainly in the background of any thinking that you have to do about this case. They appear to have died of unrelated causes, and people certainly can die of a variety of conditions in the same family. I think, as with Professor Cordner, is it possible that there was involvement by a person causing death? I can't exclude that.
So Professor Cordner has said that because of the 4th death, there could be other factors, including but not limited to homicide. You'd accept that?
I'd accept that.
Now, Professor Hilton, the view you have expressed to the inquiry in your report is that she died with and highly probably because of florid myocarditis.
Yes.
Now, having listened to the others and having in your report indicated that you're in substantial agreement with Professor Cordner,
Yes.
is this an area where you are not in complete agreement with Professor Cordner?
I don't know that I am in complete agreement with Professor Cordner. I mean, I've got my own view, and I've expressed it there, I think very conservatively, that, in my opinion, Laura might have died with or because of myocarditis.
I'm sorry, might have?
Might have died.
Is that your view?
But, yeah, that's my view. She may well have died of myocarditis. I tend to favour myocarditis over any other objective feature in Laura's death.
Well, in your report, to the inquiry, and we can put that up on the screen if you'd like. You say that died with and highly probably because of, and I think your evidence in the trial was a little different from that, in your evidence in the trial was that it was the only pathological lesion that was present that could account for her death. However, you didn't form the view with the same certainty that you have in the report to the inquiry. Has your
Well, it's certainly
mind
true
changed?
it's certainly true that that was the only pathological lesion that was observable, observed, or presented.
So your view at the trial was myocarditis could possibly have led to her death,
Yes.
which is of a different characterisation than what I've indicated you said to the inquiry. What's your present?
I think it depends upon how the strength you put on the words could have. Of course.
Highly probably did. There's some
Yeah.
distance between the two.
Yeah. And I would agree with what you just said. Highly probably did. Could have highly probably did. I would favour. There is no evidence of any. There is no physical evidence, no pathological evidence of any other cause of death. Dead, she certainly is. Myocarditis, she certainly has. Can myocarditis kill? Yes, it can. May it well have killed. Is it the favourite diagnosis in this particular case? Yes, it is. My favourite diagnosis in this particular.
Favoured, is that the word?
Favoured, yeah.
And taking into account, as each of the other forensic pathologists has, the fact that this was the fourth death, would that lead you to agree that it would not be unreasonable for a finding of undetermined to be made?
I personally wouldn't have put it as undetermined, but I can follow Dr. Keller's reasoning. This is almost a tautology. I don't think his reasoning is unreasonable.
So you don't think it's
But I
unreasonable
don't agree with it.
for a forensic pathologist to have come to the view in the case of Laura that the cause of death was undetermined?
I would not have, but I don't think it's an entirely unreasoned conclusion from what Dr. Keller's told us here today and in his writings.
Thank you. Now, can I come back to you, Professor Cordner, and I think that's your report that's up on the screen. Can we have page 77, excuse me, page 77 on the screen? Now, you attest to a different view from Dr. Carla at the time. You believed that myocarditis was at least moderate in degree, and you've heard what Dr. Carla said today about that. And then in terms of testing the
I think I say at least moderate in
You do. And you say that in circumstances where colleagues were not aware of my involvement in this case, I circulated the following email to my 10 consultant forensic pathology colleagues at the Victorian Institute of Forensic Medicine, together with a number of 5 photo micrographs which are attached as an appendix. Now, and then you set out what you said to each of those colleagues. Now, you've provided us with a letter, which I haven't tendered, but I will now, in response to questions from the inquiry to clarify various, what was considered to be inconsistencies and confusion in the original material that you provided. And that's a letter dated 8th of March. Where was it? That's not it. It's on the screen.
The Exhibit R.
Thank you, Your Honour. And now, as I said, the letter of the 22nd was to try and understand some of the matters that were set out in the various statements of those, at least some of those people who you'd provided the slides to. And I mean, in short, some referred to there being 13 slides, some referred to them being 15 slides, and there were 15 numbered slides, but numbers were missing, so there was in fact 13. That's the case? Professor?
I think that's a little bit dismissive of.
It was meant to be descriptive, not dismissive, Professor. Was it descriptive of what happened?
Maybe I'm just a bit paranoid, but so it was meant to be as simple as possible survey with not huge impact intended, but to get some sort of response from forensic pathology colleagues without alerting them to the fact that it was this case that material came from, because at the time I was interested to see what people thought as an isolated sort of case.
Now, I think you referred in your report to them being consultant forensic pathology colleagues. But I think we know from your letter, which has just been tendered, that a few of them were trainee pathologists, is that right?
Yes, but they're not included in the replies.
So of the replies that you've given us, none of them were trainees?
That's right.
And the consultants who you sent them for, were they engaged by or literally consultants with the institute?
All forensic pathology employees of the Victorian Institute of Forensic Medicine.
And you were the director?
No.
Not at that time?
No, not at the time, no.
What were you doing at that time?
Was doing what I'm doing now,
Which is what?
which is Professor of Forensic Pathology at Monash University and Head of International Programs at the Victorian Institute of Forensic Medicine.
So you weren't working at the Victorian Institute at the time you asked these people?
Yes, I was,
In what capacity?
in the capacity that I have just indicated.
I'm sorry, you're going to have to help me there.
Okay. Professor of Forensic Pathology at Monash University and Head of International Programs at the Victorian Institute of Forensic Medicine.
Were any of these consultants effectively reporting to you?
I'm sorry?
Were any of these consultants effectively reporting to you?
Definitely not.
No? You had a flat line between each of you, did you?
So they want as little to do with me as possible.
Which is quite a different point to my question.
So they have no direct line to me at all.
Thank you. Now, you sent them, I think, what were called micrographs, but there were various terminology used, and you apologise in paragraph 8 for the terminology being confusing and set out various languages. Is it the case that what you saw when you were forming the opinion you expressed in your report was slides?
Yes.
And I think there were about 7 of them. That's
Yes.
right. And there were about 7 slides, Dr. Carlo, is that right, of the various pieces of the heart?
Possibly 8 from memory.
Right. And Professor De Fleu, did you see slides?
I've seen the slides. I have no recollection how many there were.
And Professor Hilton, did you see slides?
I haven't seen slides in recent times, but I saw slides originally.
Right. And what are the difference between micrographs or the other terminology used to describe the same thing, photomicrographs, from slides?
Well, slides clearly can be misconstrued, so that slides are the word used for the microscope slides, of which you've just been talking about, 7 or 8 of them. Slides, unfortunately, in my loose terminology, also mean photographs. So I used that word when circulating the photomicrographs. I labelled them slides.
But were they actually slides or photographs?
Well, they were photographs, micro-photographs, photographs of the histology, which comes from microscope slides.
Now, I think both you, Dr. Carla and Professor De Fleu, have said something in your statements about the representative nature of microphotographs
Yes.
compared with the slides that each of you looked at. What's your view of that, Dr. Carla?
That if you look at the glass slides taken or made from tissue sampled at autopsy, each of those slides, 7 or 8 or even more, I don't remember. On a slide you have a piece of heart tissue that's been stained in the laboratory and enables the pathologist to look at it microscopically. So that's the standard glass histological slide that we all receive and look at. What Professor Cordner showed, on my understanding, to the group was digital images made from those glass slides, but of selected areas from the heart of Laura Folbigg. So
Let me stop you there. Is that what you showed them, Professor? Did you listen?
I'm hearing.
Yeah, but I'm asking you whether what Dr. Carla said is right as to what you showed them.
Well, you've got to select areas, yes. So there's selected areas, yes.
Go on, Dr. Carla.
so that there is a focus, if you like, on what Professor Cordner showed the group, as opposed to showing them the full picture of all of the slides taken from the autopsy, cut and then stained.
So what's wrong with that?
Well, he's showing them a selective amount of tissue which represents perhaps the worst areas of myocarditis, as opposed to showing them the whole of the slides that were taken from the autopsy.
Professor De Fleu?
Yes, look, I'd agree with that. In general, when you photograph a microscope slide, you can have the approach of taking a representative photograph or photographs which illustrate an abnormality. This, I think, to a large extent, or the photographs here, illustrate the abnormality. And there may very well be areas which may appear normal. That's not to say that there isn't myocarditis and that there isn't significant myocarditis here, but it's not necessarily representative. Of course, in the end, it depends on Professor Cordner's approach to this, on what basis he took the various photographs.
Were they representative, Professor Cordner?
Look, I think there is, for example, at least one of them which is low power. So it is a broader view of a larger area. Most of them accept a higher power to demonstrate the myocarditis. So I'm not quite sure what the point of this discussion is.
Your colleagues are telling the inquiry that what they think you did was provide not the slides, but photographs of them, which in and of itself changed the nature of it, and then what you provided wasn't representative.
And representative of?
What was on the slides?
Well, I'm not quite sure about that because, as I say in my report, I don't rely on the pathologist's response as saying anything about the degree of myocarditis.
Then why did you put it in your report, Professor, if you didn't?
I did put it in my report.
Why did you put it in your report if you weren't relying on it?
Well, I'm relying on it for something else.
What are you relying on it for?
Thank you. I'm relying on it for that at least a number of pathologists, 5 of them, were happy to, in the circumstances provided, regard myocarditis of the kind they saw as a cause of death.
Isn't that your supporting your position?
Hmm?
Isn't that supporting your position, Professor?
Well, I'm not calling on it as support or anything. I'm just presenting it there as an observation relevant. At the time, there was in the air the thought, is there myocarditis? What does it mean? Could this child have died of myocarditis? And at the time, there was one person saying one thing and one person saying another. And so it was to broaden the base from which a discussion was happening.
Although you were broadening the base by providing these people with something quite different from those who had otherwise expressed an opinion based on the slides.
Well, I don't think so. It was open to any of them to say, well, you haven't shown me all the slides. I couldn't show them the slide because they're labelled with the name. It was open to the pathologist to say, you know, I can't assess from these materials what conclusions to make. It was open to them to say those things.
Yes, it was also available to them to read your email, which I think you've set out. Perhaps if we could have page 77 of your report. Now, you set out what you told the forensic pathologist. If you just scroll down a little bit. And you describe her age, that she'd had a runny nose for a couple of days, playing normally, and then the pathologist gave the cause of death as unascertained, and you said apart from myocarditis, which the pathologist reported as being present, the autopsy was negative. And then you indicated to them that you would be happy with myocarditis as the cause of death. So you told them what you thought, and then you said, what do you think? Having told them what you think.
Yeah,
And then you provided them with no other information.
that's fine.
They didn't have the autopsy.
No.
They didn't have the history of Laura prior to the previous days.
And what does that tell you?
Why didn't you give them that material?
Well, it tells me that that pathologists were happy to come to the conclusion of myocarditis without that information. And any of them could have said, I haven't got enough information, and they didn't. And so that goes to the discussion about the criteria that Dr. Carla uses to say that the myocarditis in this case is incidental as opposed to causative. And I didn't want to not say what I think just sort of raises the temperature of the exercise. I just wanted it to be as mundane as possible. And as I say, following it, I'm pretty, I think, low-key about the contribution that this makes.
You yourself were content with a finding of undetermined based on there being the fourth child to die in the family, weren't you?
Well, content, I think. I said I would accept or defend a pathologist who did say that.
Why
but
didn't you
then
tell these people that that was your view as well?
I deliberately was leaving out that this was this case. I was deliberately trying to get a response from the pathologist on the basis that this was a single case.
Which it wasn't.
Well, no, it wasn't, of course. But if if there's any inference in there of misleading, I think that is not fair.
Can I suggest to you, Professor Cordner, that the inquiry should have no regard to the views of your consultants as set out in your report, given the circumstances as we have discussed around those views being obtained?
Well, No, I don't agree with that, but I don't rely on this as high science. It is perhaps even relatively informal contribution from colleagues that presented as an ordinary case in trying to strip away all of the drama associated with the case to see what colleagues would say.
By drama, you mean the previous death of 3 children?
Yeah, but I'm not. I mean, we would have had to do. I would have had to do something different.
Why did
to
you
that.
do it at all?
Well, I've told you before that I mentioned before that at the time I wrote this report in 2015, the understanding that myocarditis was, as it is, I believe, a significant part of the discussion of this case. There wasn't the understanding that it was clear that Laura had a very serious condition which could account for her death. It seemed somehow to have disappeared slightly from view.
Then you accept that those comments can't be used to support your view.
I didn't accept that.
Well, you did in your report. Do you want me to take you where you said in your report that you accepted that their comments can't be used to support your view?
No, that can't be used to accept my view about the severity of the myocarditis. That's what I said.
I think it's further down that page. We'll just see what you said, Professor. If we keep going down to the next page. Now, I think it's in brackets on the first paragraph. The comments cannot be used to support my view that the myocarditis is more than patchy and mild, as obviously the pathologist only saw what I sent them and did not view the entirety of the 7 slides. So what do you rely upon it for?
Well, I'm sorry, did you say that I had been misleading before?
No, I'm asking you, you're saying it can't be used to support that view,
Yeah,
so
well-
what view is it supporting?
You misquoted or misunderstood what I'd written here.
But it's there.
The tenor of the replies goes to the point that a number of pathologists, about 5 of the 10, in the circumstances as described, which did not include the fact of the 3 previous infant deaths in the same family, the myocarditis was regarded as sufficient to be a reasonable cause of death. And that's as far as it goes.
I understand that. I'm just trying to understand what it is that the comments can be used to support, given
Well,
what
I've
you
just
said.
mentioned that. Just mentioned.
So that's your answer.
Goes to the following point, that for a number of pathologists, in the circumstances as described, which did not include the fact of 3 previous infant deaths in the same family, the myocarditis was regarded as sufficient to be a reasonable cause of death.
Thank you, Professor. You've referred before to Professor Polenen's report,
Yes.
which I think you've indicated the circumstances in which it was obtained as well. Can we have that on the screen? Page 3. Do you see there's the heading, Dr. Carla is not an outlier? And Professor Polinen says, the reader of the report may get the impression that Dr. Carla was an outlier in his professional view, and the professor states he was not. The report, that's your report, does not discuss that forensic pathologists in the late 20th century were embedded in a professional culture that permitted us to make conclusions about homicidal asphyxia in cases such as the Folbigg cases. Specifically, when Dr. Carla's opinion is compared to American forensic pathologists, some would have concurred with his view, and there are still echoes of this approach even today. Do you accept what...
Can you read the next paragraph too?
Over the next page, That's a separate heading, paragraph 2.
Yes, I do.
Thank you. Finally, if I can turn to the microbiology in respect of Laura, and the reports are at tabs 47A to D. We can have them on the screen. Now, I think all of you have probably seen these. Is there only one page? There's 4. So if you can indicate when you want the pages to be. There you go, there's 2 at once. Professor De Fleu, have you finished having a look at them?
Yes, I've got them here.
What is your view as to what they represent?
I think, as in the other cases where microbiology has been performed, that the orthodox view would be that this is likely contamination in the main.
Thank you. Dr. Carlo, are you still looking at them?
No, it's fine.
What's your view?
I agree with Professor De Fleu.
Professor Hilton?
Yeah, well, Professor Ben's stated opinion in part there's profuse post-mortem contaminants.
Sorry, I'm having trouble hearing you, Professor Hilton.
Yeah, sorry, Professor Ben, who is probably the author of this report, says that under miscellaneous that the tissue biopsy culture source lung profuse post-mortem contaminants. And I think that's in agreement with the opinions expressed by all of us in regard to post-mortem microbiology in general.
Thank you. Professor Cordner?
I've got no comments. I mean, there's only, it's interesting, not of minor interest, Dr. Carla didn't see any abnormality to the heart, so he didn't send any heart for microbiology, but that's just an observation because he regarded the heart as looking normal at the autopsy, so that's fine.
But in relation to the, under the heading miscellaneous,
Oh,
the coliforms, the moderate coliforms, and the profuse.
yes, I've got nothing more to add to what's already been said.
Thank you. Your Honour, that's all the questions I have in relation to the 4 children. There are...
One matter arising, I think, Ms Furness, and perhaps Professor Cordner, in your report at page 79, you referred to a paper by Weber and others. And in that paper, they describe the death of infants under the age of 2 as, from myocarditis, as a rare event. Do you recall the paper?
Look, I can't recall it in particular, but I can access it.
Do we have the
We do.
paper here?
We do have it here. We probably have it in an electronic form, but I'm confident.
Well, we won't hold up proceedings at this stage, but I'd be great. We won't hold up proceedings at this stage, but I'd be grateful if you would have a look at it,
It might take me a couple of days to get it, Your Honour.
Your Honour, we have it on the screen.
we can give it to you better, faster than that.
Can we put it up on the large screen?
I think perhaps on the first page of the report there's a sort of a summary of the findings.
The first page, did you say?
I think it's the first page, but not of your report, but of you refer to it at page 79 of your report. But I'm saying that I think on the first page of the article that you've referred to, the Weber article, and the survey that they did, which I think you've described as 1,516 paediatric autopsies over 10 years. And they looked at 28 cases of myocarditis death. One of them was 16 years of age. So, have we got the article there yet?
Yes, it's about to come up.
You just need to be a little bit careful about making a conclusion about the incidence from that. It would depend upon the population from which those autopsies are derived.
Mm-hmm.
So, so that would be the thing to find out.
But I'm just referring to the conclusion that they came to about the rarity of myocarditis death, whether from a prior illness or symptoms or symptomless.
Thank you.
And the conclusion that that's a rare event. Is it up somewhere?
It will be, Your Honour.
Okay.
Perhaps just why it's coming up, Your Honour, with your leave, I will sit down
Certainly.
and resume the remainder of my questioning of the forensic pathologist after my friends have finished their
Yes.
examination, and of course they will have the opportunity if anything arises.
Yes, certainly.
Thank you, Your Honour. Is it coming up? Perhaps we will make a copy available overnight to Professor Cordner, and it can be dealt with tomorrow.
Yes, that would be the best way to do it. I think you need to read
I'm
the
sorry, I should be able to produce it, but I can't.
No. Well, you referred to it, so that's how we came to read it. Yes, now, in terms of the next examination, Mr Morris, is that you?
Depends on Your Honour's convenience. I'm happy to go now or...
Yes, well, I think... wait till I just see... Ms Richardson, would you prefer to wait till after Mr Morris?
I have questions, but I don't have a preference. If I had understood Mr Morris wanted to go last, but it's a matter for him.
Mr Fraser?
No questions, Your Honour, to assist.
Okay. Ms Mathieu?
My questions may be dependent on what Miss Richardson's questions are, but say for that, I'm happy for Mr Morris to go first. I anticipate he might cover many of the areas.
All right, thank you. Mr Morris, it's to you.
Thank you, Your Honour. Thank you. Gentlemen, there was some discussion yesterday in the morning about the difficulty in estimating a time of death from body temperature and so forth, and people's perceptions of it. And as I understand the position, different people can have different perception of body temperature when they touch the skin. Is that correct?
Yes.
Professor Cordner?
Yes.
And would it also depend on whether the core of the body was touched as opposed to the extremity?
The core of the body would never be touched.
I'm sorry, if an ambulance officer, for instance...
Right, yeah. No, they're not going to be touching the core of the body. They're going to be touching the exterior of the body.
Oh, sorry. So, what I'm talking about is there a potential difference between touching a limb and touching the abdomen?
Yes.
Yeah.
Yes.
Potentially, yes.
Well, it would depend on whether the trunk is clothed and the limbs unclothed. I mean, so that might tend to keep the trunk warmer and the limbs getting cold. But just as a general observation, if I may, I think it's very tempting to try and ascribe lots of significance to findings of dubious value in the first place, so I think we've had quite a bit of discussion about findings of a number of different kinds, which really are very marginal in mainstream forensic pathology practice.
Thank you. Are there any studies that have been performed about the rate at which a body loses its temperature? I might refer Professor Hilton to you first.
Yes, there have been multiple studies over many years. Estimating the time of death is the holy grail, if you like, of forensic pathology. Many people with much greater minds than mine have applied themselves to this over many years. There's a commonly published nomogram which superficially looks very, very attractive, which pretends to give a better estimate than most of the other calculations, if you like. But even that's, if you read it carefully, fairly flawed. The answer, I think, is that arriving at the time of death from the estimation, from the measurement of core temperature of the body is fraught with difficulty. And even to the extent of what's meant by the core temperature of the body. Now, the usual, or most usual, or most common avenue of investigation is the rectal temperature using a rectal thermometer. Some unpublished work that I've done myself shows that there's very often a difference of up to 2 centigrade degrees between the core temperature as taken by that route compared with the core temperature taken by an incision in the skin and a thermometer inserted into the liver. So, in short, body temperature is not an entirely reliable indicator of time since death.
I see. Is what you're saying that the cooling of a body is dependent on a whole host of different factors?
Yes, and Hassinger in his nomogram tried to make allowance for at least some of these.
Okay. Does anybody else in the room have anything to add to this discussion?
No.
No?
Could I ask a question?
Yes.
And that is, does it make any difference if you're talking about an adult or an infant?
It is said that infant bodies tend to cool more rapidly than adult bodies. I don't know that there's any decent scientific evidence to support that belief.
Dr. Carr?
I'd agree with that.
I'd agree with that as well, Your Honour. Almost all the research that's been done on body cooling has been done on adults. There's been very little work on small infants.
Thank you. Professor Gordon?
Yes, I would be surprised. I certainly have never given evidence in a case drawing on something about temperature of the body to make conclusions about the time of death.
Does that mean that you don't know? I think Professor Hilton, you said that there's a view around that the bodies of infants cool faster.
Yeah, I think it's based on the various ratios of the child volume, the child's skin area. But I reiterate, to my knowledge, there's never been any decent scientific studies to tell one with the other.
Any experience, Dr. Carla?
No?
Dr. Defoe?
No.
Thank you. Thank you, Mr. Morris.
Thank you, Your Honour. Now, Professor Cordner, in giving your evidence this morning, you made reference to the importance of a multidisciplinary case conference. Is that something that takes place in Victoria, or what's the genesis of this multidisciplinary case conference?
Well, if it does take place, it doesn't involve us, so I'm not aware that it does take place. It maybe takes place within the Department of Health in a slightly more immunised, circumscribed place, armed with document, but without direct involvement of some of the people involved. So I'm afraid I can't give you a direct answer about that in relation to Victoria, but it's clear from the literature that this has been a significant part of the post-death infrastructure for infants and even young children in the United Kingdom. And clearly, I mean, that's where the literature that we've discussed in this case so far about the recurrence of SIDS in later families and the relative risk of natural death and unnatural death has come from. And it's a result of the large-scale availability of post-death reviews involving a range of experts.
Just in relation to the range of experts, I'm just interested in the limits, perhaps, of the forensic pathology opinion and the extent to which a forensic pathologist may conclude his or her work, provide an opinion on autopsy and so forth, and then what role is there for the forensic pathologist to make recommendation for review by other specialists or other areas of speciality. And when you talk about the comments section in an autopsy report these days, is that something now that is forming part of forensic pathology practice, or is that sort of thing left to other people to decide?
I think there's different practice in different states. So some states do have more expansive comment sections than others. So that's the answer to that question. I think a related question, I think, is how does a pathologist deal with suspicion, with concern, and at what point does that get committed to writing, and at what point does that constitute evidence, and if that is to happen, then how is that substantiated?
Right. And in order to allay suspicion, and I take it from that answer that you gave that we're talking about perhaps undesirable human intervention in relation to the death, suspicious circumstances, what steps, if any, does a forensic pathologist take to try to trigger investigations by other specialists?
Well, that is really, there would either be institutional mechanisms for that, or there would be left to the individual pathologist. But of course, in a case like this, there'd be more than one who would know that it was going on, so there'd be multiple minds brought to how to deal with concerns and suspicions, I suppose.
Would anybody else wish to comment upon this general topic, perhaps? Professor Fleur?
I think if I can go back a number of questions which related to multidisciplinary institutional reviews. At the time that Professor Hilton started in New South Wales as director, I can say that he instituted a program of regular review of our infant deaths. But I suppose one of the limitations of that was that effectively it involved the forensic pathologists. It was not multidisciplinary, but it was multi-person. The child death review team in New South Wales is multidisciplinary, but in my view it has a couple of limitations. The first one is, for example, it consists of paediatricians, some police members, some members of the bench. It includes a forensic pathologist, at least a number of years back, but it wouldn't include microbiologists or neurologists as an example. So that's problem number one. And problem number two is that their deliberations are confidential. And it's certainly a complaint by a number of forensic pathologists that I'm aware of where they would like to, in fact, get feedback in relation to cases. And instead, all they find out is that in the annual review document, it becomes a matter of trying to guess if it's one of your cases or not. So there are such facilities in place, but they certainly have some major deficiencies.
Professor Hilton?
Yeah, I mean, Professor Fleur's given a good account of it. Within the Institute itself, there was a fairly, at least I hope there was a fairly collegiate sort of approach to things, and there was a daily case conference, for instance, but there was also a meeting of minds with varying frequencies according to different cases. I might say not always agreement of minds, but meeting of minds. Outside of the Institute, there was a cot death review committee, yes, which in actual fact was chaired by the state coroner, but included forensic pathologists from Westmeath, from Glebe, and from Newcastle. Tim Lyons came down. I've got a record of Tim Lyons coming down once. There was social workers. They were grief counsellors, actually. Yeah, we had a team of grief counsellors that used to talk to the relatives of deceased persons that came to our attention. Ambulance officers. Can't think of anyone else that
Paediatricians.
Clinical paediatricians. So that was another. But this was more concerned with the, if you like, the domestic arrangements for examining and suddenly dead babies and how to get them to us in good time and what sort of investigation should be done by which particular individuals. And then there's the child death review team. Now, I was one of the movers to get the child death review team up and running, and it was modelled, or it should have been modelled, on the committees of confidential inquiry into maternal deaths, anaesthetic deaths, and surgical deaths, all of which I had at one time or another been a member. Now, these committees act under terms of strict confidentiality. And the idea being that anyone can come forward and give an opinion on a relevant aspect of any given death. It publishes an annual. Each of these committees publish an annual report, and the cases are anonymised. They may quote individual cases, but they are anonymised. The individual pathologist would not normally have access to any individual case that this committee has examined.
Have you had the answer to your question, Mr. Morris?
Yes, Your Honour.
Thank you.
I guess the issue, apart from that system of case review, Am I to assume that the purpose of the forensic pathologist report is to try to identify any, either macroscopically or microscopically, microbiologically, etc., any disease process that might account for the death?
Yep.
Yes. Yes, largely.
And is it possible... The question I've got is the issue of whether one approaches a problem, that is, cause of death, through the prism of one's own speciality. And the extent to which other specialists in other fields may be able to contribute to an understanding of disease process or other condition which may have given rise to the death. Now that's... Sorry, Professor.
Sorry, I'm sorry. No, I'm not going to...
Now, it seems from the autopsy reports that we have in this case relating to these 4 children that none of them have suggested any further inquiry from any other specialist that may be informative as to what the cause of death is.
No, that's a misapprehension. A neuropathologist would almost certainly in our institution, be involved in the case the case diagnosis. Microbiologists obviously were, because we've seen the report. Virologists obviously were, because we've seen their report. There are other. We didn't, in my time, do anything very much in the way of genetics, but I understand that developed later on. So you got the benefit of geneticists giving their input. And I suppose it boils down to, it was the forensic pathologist's privilege that he or she could consult with any other expert that he or she felt appropriate.
And so, for instance, specifically in relation to about 2003, Professor Hilton, at one point you were seeking the assistance of a gentleman by the name of Drucker.
Yeah. Yeah.
Could you just tell us about that?
Yeah. Well, point one, I think by the time that occurred, I was no longer involved in the day-to-day activities of the institute. Drucker was a microbiologist working in. I think you're right. He's a microbiologist working in Manchester. Somehow or other, I found out that Dr. Drucker was working on genetics and genetics of sudden infant death syndrome. So it was decided by the Defence Council, or the Defence Council and their instructing solicitor, my having brought this to their attention to consult with Dr. Drucker as regards, I think it was Laura, and as far as I know this was done, but I'm not entirely sure what the outcome was. But in any event, it was decided overall that not to present Drucker's evidence, and certainly not to call Drucker, because he was there and we were here.
Quite how far that went, as at the time of trial, you're uncertain whether a report was prepared or not.
To my knowledge, Dr. Drucker wasn't called.
But you're not aware whether he prepared a report or not?
I've seen some writings from Drucker along this. I don't know that it was in the form of a formal report. I know he was suggesting some further testing when it was decided that this further testing wasn't really feasible in this instance.
But what you're saying...
Can I just say that this was almost the genesis of the modern era of the examination of the more esoteric parts of aspects of SIDS, like genetics and what have you.
In fact, this was really the start of the opportunity to obtain genetic testing on post-mortem tissue, or close to the start.
In this context, yes.
And there's been a significant change since those days to days now. Is that correct?
Well, there's been an expansion.
Do you agree, Dr. Carl?
Yes. Yes, absolutely.
And that provides a great deal of opportunity, can I suggest, for further investigations of post-mortem tissue.
Yes.
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 And as I understand it from, it's expanded the opportunity for other specialities to become involved if various genetic markers are identified, or genetic anomalies. Is that correct?
Yes.
Yes.
I think it's more than that. There's certainly some recommendations that in any case of sudden infant death syndrome, that there be cardiologist review of the family, irrespective of any cardiac genetic outcome.
Is that as a standard procedure?
It's in some parts of the world, yes. I'm not certain if that's the case in New South Wales at this stage.
Does anybody have any experience in other states about this, the introduction of this sort of inquiry these days?
Genetic
Yes.
testing.
And cardiac assessment?
Well, yes, they overlap, and I suppose that the fullest possible involvement of that would require cardiac and genetic testing of the family in order to focus on the infant. But what tends to happen is it's the other way round, that the death of the infant, the infant's genetic material may be subject to a battery of genetic tests to see whether any of the known genetic markers are there for arrhythmic inherited diseases. So that's what we do at the Victorian Institute of Forensic Medicine.
Dr. Carla, in South Australia?
I'm in New South Wales.
Oh, sorry, you're in New South Wales. Yeah, you were in South Wales.
In Newcastle, but our facility is connected to John Hunter Hospital, and there's the Hunter Genetics Laboratory nearby. And if it's thought that further testing, re-genetics, is warranted, then I have personal contact from time to time with geneticists in the laboratory, and there's an open discussion. There's regular meetings between members of our department and their department and cardiologists to discuss problem cases. Yes, to answer an earlier question of yours, the landscape has changed greatly over the last about 15, 20 years in relation to this area.
And putting aside cardiology, what about, and we know that in these cases the metabolic disorders were assessed,
yes,
and the most common metabolic disorders had been at least addressed and came back with negative results.
yes.
But putting aside the metabolic disorders and putting aside the cardiac disorders, what opportunities were there in 2003, Dr. Carla, to assess any other potential congenital abnormality that may give rise to a sudden infant death?
I'm not aware of back in 2003 what we were specifically doing, other than what's already been generally mentioned. And of course, you'd be aware, it wasn't that we were doing something different in 2002 and in 2003 on January 1, it all changed. It was an evolution, and a very slow evolution, and it was piecemeal. So some states were doing it at possibly a more rapid level than other states, and so on. But so it was a slow transition process to where we're at today.
Professor Hilton, anything to add?
Not within these particular confines. I mean, in an ideal world, every baby that dies suddenly and unexpectedly would be subjected to a whole battery of genetic, metabolic tests. Unfortunately, we live in the real world. This is A, very time-consuming, B, extremely costly, and I'm afraid it boils down to who's going to pay. So there's got to be some selection somewhere along the line. And a lot of the work is done because from people's own scientific curiosity, and they'll absorb the costs into their overall budget.
Anything else to add on that question?
Just to, I hope this is relevant to the question, but you can go so far trying to exclude all the conditions, but even when you do, if you look at the lists, for example, of what causes acute life-threatening events, at the bottom you see 25 to 50% idiopathic. So in other words, you do everything you can think of and you won't find the answer in cases where there's been a definite acute life-threatening event. So there is still a lot that is not known, and that is the enigma of infant deaths that permeates this whole field that we've spent the last 2 days talking about.
And in that regard, I think Professor de Fleu, and picking up on your comment, Professor Cordner, if we go to, just to illustrate that, if we go to Exhibit L, Your Honour, at page 31 of Professor de Fleu's report, I don't know whether, does that come up on your screen?
No.
It's Exhibit L.
Yeah, I'm sorry, I can't help you, Jeremy. I'm sure someone...
Yes. If we go to page 31 of that document, please. I don't know whether you can read that. Right, and this table. Now, Professor Cordner, this is the potential range of medical conditions that could give rise to what they call...
I had my own list in my report.
I'm sorry, I don't suggest that Professor de Fleu's
that
has improved on yours, but it's just the one that I happen to choose.
Yes.
And with respect to the investigations here, I don't know how many potential options there are, but there's obviously a very wide range of matters that might suggest an ALTI. Is that correct?
Yes.
Yep.
Yes.
And they can essentially present in a very similar way to the symptoms that Patrick experienced in October of, I think, 93, excuse me, 90, in October 1990. 18th, I think.
Yes.
Correct?
Yes.
And in this case, of course, back in 1990, there were limited opportunities to genetically assess cardiac function, I take it.
Yes.
Sure, yep.
Yes.
And the metabolic disorders, and I take it, Professor De Flue, that this is a list which is a current list rather than what was known in 1990.
Well, that's a list from 2007.
Right.
It's an illustrative list. I'm certainly not putting it forward as the best list.
I know.
But yeah, it's to me a not unreasonable list even today.
But we know that a number of the metabolic disorders have been excluded in Patrick, at least after his ALTI.
Yes.
On the tests available at the time and the knowledge available at the time, yes.
Yes. Anything to add, Professor Cordner?
What's the question?
Well, the metabolic disorders, based on the knowledge they had at the time, 1990, and the testing that was available, they excluded the metabolic disorders at that time.
Well, I think it would have been slightly less available, advanced, compared to 2003, yes.
But you'd agree with me that it would be, certainly it was, as at 1990, the clinicians couldn't deal with an in-depth assessment of all these potential conditions. Do you agree?
And any given baby?
Sorry, no, in Patrick.
Patrick, I think they did the best they could in the time that they were living and the state of knowledge under which they were practising.
Yeah. Professor Dr. Carter?
I was a trainee in 1990, and I don't want to present an image that in 1990 was Stone Age medicine. It was actually very different from today because technologies are obviously improved. But as far as what was testable metabolic abnormalities, there was a vast number of disorders that even then were able to be tested for, including, I dare say, all of those ones on your list.
Okay. We will... Your Honour, what I might do, given the time, is I might depart from this topic and come back to it tomorrow, but just letting the experts know that I will be returning to the ALTI type aspect tomorrow. Now, I'll deal with some shorter points in the time I've got. The existence of... we had a discussion about the froth and blood in the mouth, and it's fair to say, and this is in the mouth of Caleb, or around the mouth of Caleb, is it fair to say that the consensus is that that froth and blood is non-specific as to identifying cause of death?
Yes.
That's my view, yes.
Yes.
Yeah.
Absolutely not.
Yes, thank you. And in relation to hemosiderin in the lungs, it's fair to say that that too is non-specific in distinguishing between an infective cause and a physical constraint upon a person's capacity to breathe. It's a non-specific finding, is that right, Professor Cordner?
It started out, people thought it might be a marker of imposed upper airways obstruction, but as the research unfolded, it was found to be present in undoubted cases of natural causes in SIDS, so I think the view is today that it is not a positive indicator of superimposed upper airway obstruction.
Does everybody agree on that?
Non-specific finding.
I'm sorry, both of you agree?
Yes.
And is hemosiderin something that can be caused by infection? Do we know?
Hemosiderin is caused when, as part of the breakdown of red blood cells and the residuum of the components of the hemoglobin within the red blood cells, it's iron. Now that's the common reason it's found under these circumstances. Do you see it at other times in other conditions? Yes, you can. Look, I don't want to go on telling very interesting, totally irrelevant clinical stories, but I spent 20 years in Western Australia. Now, the West Australian health people were absolutely terrified there was going to be a rerun of the asbestos disaster, but not asbestos with iron ore mining. And a directive went out that every lung section going through the Department of Health's laboratories, where I worked at the time, was to be stained for iron. And yes, we stained for iron, and did we find it? We sure did. And we found it in a broad range of lungs from a broad range of people from a broad range of geographic areas. What does it mean? It doesn't mean very much at all in isolation.
It's old bleeding. It's a response to blood, as Professor Hilton has indicated, and it's a response by living tissue to the breakdown of haemoglobin, which is in red blood cells. And so the cause for that bleeding is unknown. All you have at the end of the day is a cell with brown iron granules in it, but you're unable to say how that blood where it came from, but it's ended up in the lung as a hemosiderin granule.
I think one other, and I agree with both my colleagues, but one other aspect that is important is that it takes a number of days, probably, for hemosiderin to be produced after the blood is deposited. So if there's an event which causes bleeding into the lung tissue, you will not concurrently see hemosiderin as a result of that event. It will take days before it becomes apparent.
Dr. Cully, you're nodding your head. Yes. Professor Cordner, you agree?
Yes, I do. Yep.
Yes.
So are we talking 2 to 3 days from or do we know? Or?
Probably as a minimum, but those cells, the hemosiderin-laden macrophages, may stay there for weeks, months.
Or years.
So you don't know when the acute bleed was. All you've got is the evidence for that by looking down the microscope at the hemosiderin macrophage.
Okay. Thank you. Now, Professor Hilton, you were talking about the uvula in Sarah.
Yep.
And the potential impact of the uvula striking or coming into contact with the epiglottis.
Or getting stuck behind the epiglottis.
Or getting stuck behind it. If the uvula was to get stuck behind the epiglottis, what would be the effect?
It would cause a serious obstruction to respiration.
And is that something that could trigger an unexpected death?
Yes.
And you indicated that the uvula demonstrated, you described the uvula as having a reddened appearance.
Yes.
And is that consistent with an inflammatory response from infection?
Yes.
And is it also possibly explicable by the uvula actually coming into contact with the epiglottis?
Yes.
Or in fact getting stuck behind the epiglottis on a prior occasion?
Hadn't thought about that, but I suppose so.
And you told the Commission that when you performed the autopsy and gave your evidence at trial, that you thought that the position of the uvula on autopsy was most likely artefact from the forensic process?
I regard that as a very real possibility, and it was, I had never heard of it being described before, yeah? So this is my vast series of one case. And in fact, it has troubled me ever since I did that autopsy. And it was only in the last few days that I found another case recorded somewhere else in the literature.
Why did it trouble you, Professor?
Well, because it was there, and did it contribute to death? Did it not? Was it an incidental finding? Did I, in actual fact, create it? I don't know. I don't know an answer to any of these. Still don't know the answer to any of these questions.
Except to say that there's another recorded...
There's one more recorded case as far as I can find.
And that's a case note, is it, or is it
It's part of a published paper.
And is the published paper, this one, I think it may have been circulated, Your Honour, somehow I received a copy of it, Your Honour. I can clarify it overnight. Is it this Odo Laren? Could I hand it to you?
Yeah, that would be great. Because I came in here with 3 copies this morning and they've all disappeared from my... Otolaryngological aspects of sudden infant death syndrome, and it's by Marin, Cinnamon, Castellanos and Martha Cohen. Now, I don't know the first 3 authors. I certainly know of Martha Cohen. It was published in the International Journal of Pediatric Otorhinolaryngology in 2012.
Mm. And Your Honour, rather than taking the witnesses to it, perhaps what we might do is get a copy of it and we can circulate it to the other experts, because I'll have questions of them.
Screen.
Oh, you've got it on the screen?
Yes.
Oh, could we have it up on the screen, please, Your Honour? Or should, excuse me a moment, Your Honour. Gail, should we give it to them overnight so that we can...
It's not, you can talk.
Excuse me a moment.
It's not mine.
Oh, right. But all the experts... Have all the experts received a copy of this paper?
You wouldn't have.
I haven't.
Okay. Well, Your Honour, we'll make those arrangements overnight and we'll take it from there. The Professor de Flue, just in relation to the timing of the feed of Caleb, and the information which learned counsel assisting provided to you that Caleb was fed about 1 o'clock. I want you to assume that he was found roughly at about 2:55. Now, working on the basis that the around 1 o'clock may have a degree of flexibility, but the 2:55 is more or less fixed, does that necessarily change your opinion with respect to the finding of a large quantity of curdled milk in his stomach on autopsy?
No, it does not. If you look at it, on the face of it, accepting that there isn't a measurement, a large quantity to me means, a fairly full stomach. And in a situation like that, it would likely be the case, and I emphasise the word likely, that death occurred closer to the time of the feed being taken rather than some hours later.
Right. Now, the other thing is the discussion this afternoon about the IL-10 gene and so forth, and Professor Carley, you were specifically taken to that with respect to a letter from the Department of Public Prosecutions to Legal Aid. It's fair to say, though, that, is it not, that microbiology and issues of immunology have become an increasingly important aspect of, certainly in the clinical sense, with respect to the understanding of SIDS. Is that correct?
When you say in the clinical sense, do you mean with live patient examination?
Okay. Certainly in the research area.
Yes, I'd agree with that.
Have you got any knowledge of whether it's become important in the clinical sense?
Look, I'm not an expert on paediatric genetics or microbiology, but in the passage of time since 2003, I'm sure when I say our, I mean the medical fraternity generally and scientific fraternity, our level of understanding of immunology, immunological processes and disease relating to immunology has, as you'd expect, expanded hugely. But the difficulty is translating that research and also clinical practice in live children, to be specific about this, to use that body of knowledge in relation to the investigation of sudden unexpected deaths in infancy is somewhat of a disconnect. We're not able to test for specific levels of immunoglobulins or other immunological agents at autopsy. We can do special stains looking for certain immunological markers in all organs of the body. We've been capable of doing that now for decades. But how that translates then into giving us a better understanding of how these children died is still open to debate.
So those limited tests that you're talking about really represent the limits of the capacity of the forensic pathologist to identify the link between a potential immunological or infective process and whether it had any contribution to a sudden and unexpected death. Is that correct?
Yes. The autopsy is somewhat of a blunt tool. There are many things that we can do, more than what we used to be able to do, but there are still limits on what we can do. We can send tissue off for culture. We can do swabs and send it off for viral testing in a way that has completely revolutionised the way that we used to do things. For example, we used to culture pieces of lung for virus detection. That's no longer done, and a specialised technique called PCR is done, which gives you a battery of tests against many more viruses in lung, but other tissues as well, and very rapidly. The viral culturing took many days. This can be an overnight test.
Yeah, I mean, there's been a suspicion that there's immunological type problems associated with SIDS for decades. And way back in the 1980s, the team of which I was a member at the time did publish about allergies and hypersensitivity to 3 common allergens in SIDS. We published it, and as happens, someone else replicated our work and didn't find the same results. However, they didn't quite use the same technique either. So there is an introduction of an idea, and it may be followed through for years and years, or it may not. it may get lost. The other thing is that every year, almost, there are new techniques being introduced. Some of them are applicable, at least in theory, to SUDS. Some probably aren't. Now, I think what you may in part be alluding to is Robert Clancy's work on immune bodies and whatnot in lung excretions, the eosinophilic exudates. And I think Caroline Blackwell talks about that as well. And that is an interesting research technique which may or may not have practical application.
Anybody wish to add to that?
Oh, only that more and more of the enigma will be unravelled the more research there is, particularly research that is done in association with the places where the autopsies are undertaken.
Now, just, Your Honour, if we might bring up Exhibit D, which is the textbook by Bayard. One of the issues, gentlemen, that not only is the autopsy a blunt tool, to use your word, Professor Carla, but the risk of, there are inherent problems with microbiological testing of samples at autopsy.
Yeah.
Yes.
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 And we talk about contamination, is His Honour to form the view that because there is contamination with 1, 2, 3 or 4 different bacteria identified on microbiological assay, that somewhere on that body is the relevant bacterium that's been identified?
Well, the bacteria described as being there are described as being there because they were there, but they're not there in everybody.
I may not have been clear. If it's a contaminant,
Yeah.
is it likely to be a contaminant from the body of the deceased?
Oh, I see.
Yeah.
Yes.
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 So, although there's a contaminant, let's say streptococcus, found in the lung, during the autopsy process, what did I say, staphylococcus?
Staphylococcus.
Let's take staphylococcus. Assume there's staphylococcus found in the lung. Is it to be understood that that staphylococcus has found its way into the lung from some other organ within the body?
It's possible.
There's a strong possibility, yeah.
If it's a contaminant, yes. If it's not a contaminant, then it can be assumed that the organism was present in the lung. Staphylococcus should not be normally present within lung tissue. In other words, it's there for a pathological reason.
So if it's there and it's not a contaminant, it's a pathological.
Yeah.
Yes.
Yeah.
It may be. It may be.
And to determine whether it's pathological or not, is it legitimate at all to look at the clinical history of the deceased?
Yes.
And Dr. Carla, what would you be looking for?
With reference to staphylococcus in the lung, as Professor de Fleur has said, it's a pathogen. In other words, it's an organism capable of causing disease. Shouldn't be there in the first place. I would expect that child, if it's a child, to have symptoms of a lower respiratory tract infection if it's way down in the periphery of the lung, with fever, cough, might even, if it's developed pneumonia, maybe cough up a bit of blood, look unwell to an observer, and then if testing is done, chest x-ray, blood test like a full blood count may show evidence of an infection.
Okay. But of course, when you're in the autopsy situation, those tests those tests, some of those tests aren't available.
They're not available. Some of them are not available. Certainly the culturing of the tissue is available.
And would we also be looking for signs of inflammation in any of the organs?
Well, in the lung, yes. So you would, if you suspected staph pneumonia in the right lower lobe, for example, I would take multiple sections through that right lower lobe to prove or exclude my suspicions that it was pneumonia. And I might take 3 or 4, depending on my level of suspicion.
And why would you take 3 or 4?
Because it can, if you only took one, it can be missed. So I would take multiple sections to improve the yield, if you like. And that's what pathologists often do, is form a suspicion or a view that's preliminary and confirm that by further testing of tissue, by taking multiple samples of an organ and then have that tissue processed and made into slides.
To try and minimise the risk of a false negative. Is that really what we're saying?
To confirm your autopsy findings. You need to do that. It's not just a naked eye science. If you're saying somebody has died of pneumonia, particularly if you want to name it staphylococcal pneumonia, you should prove that staphylococcus is in the lung and then also prove that that person has pneumonia and it's of a degree or severity that would be capable of causing death.
Professor?
I'm not disagreeing with anything my colleague said, but I would point out that it's more likely that Streptococcus is a genuine villain rather than staph, as far as finding bugs in lungs are concerned.
Okay.
If I may just add, the part of the problem with getting a positive microbiology result is that you get that a number of days after the post-mortem. By then, the chances are there's no real opportunity to go back to the body to get more lung tissue. And especially in babies, it's certainly my experience that the naked eye diagnosis of pneumonia is very unreliable. So sampling, knowing where to sample, becomes very difficult. So you may entirely miss it.
And we're talking about sampling for the purpose of microscopic examination.
Yes, correct.
Now, with respect to infection, I'm sorry, I don't mean to neglect you, Professor Cordner. Do you agree with that?
Look, yes, I'll just make one comment, which is that in the well-established pneumonia, there's no issue. In the disease as described by Dr. Carla in its full manifestation with fever and cough and coughing up pus and blood and obvious pneumonia under the microscope, then the cause of death is going to be pneumonia. The issue comes up in these cases in relation to SIDS, as we've mentioned a couple of times, is when the histological appearances are minor or minimal. You've got the positive culture. Is it contaminant? Is it real? And then are there, so it's not pneumonia, it's not obvious pneumonia. Some pathologists say the minor infection is the cause of death. These days most probably don't. And this is the space where some researchers are trying to find out whether the organisms have other ways of causing serious illness, such as by producing toxins that might be absorbed by the baby rapidly and cause serious illness and death, in the space of a couple of hours. So that's where the issue is, in my understanding of at least part of the research effort in respiratory tract infections.
And adding to your list of integers, a clinical history of being unwell moderately unwell over previous days.
Well, yes, so the question becomes, did the baby die with the signs of the mild respiratory illness, or is there some explanation that we can't see and recognise that actually means the child died of it?
And this has evoked research interest because a history of prior mild infective illness has been identified in about half of SIDS cases. Is that your understanding?
Well, but as I mentioned there, I think there's a range of views about that, but it's in my understanding that mild viral type illness is regarded as part of the prelude to SIDS.
Is that a convenient time?
Yes, Your Honour, thank you.
We'll adjourn till tomorrow.
Adjourn.